What is the ventricular rate?
Dissociation.
What is the ventricular rate?
25.
So the ventricular rate here, it will be 300 divided by
Ventricular rate is about 27.
10.
yes, 300 divided by 1, 2, 3, 4, 5, 6. So 11. It will be 27. Complete heart block. Why? Because the ventricular rate 27 and the atrial rate the 300 divided by BP.
Because there is dissociation between the ventricular rates and atrial rates.
Yes, excellent. So here 1, 2, 3, 4, 5. The 300 divided by 5, it will be 60. So the atrial rate is 60 and the ventricular rate is 27. So it means complete dissociation. It's a complete heart block. And this ECG for sure it will be ventricular tachycardia and atrial fibrillation. Be familiar. Any ECG in the exam with irregular rhythm, so atrial fibrillation until proven otherwise. Okay. So here, anyway, in this question, be familiar with all ECGs. Once you see the ECG, you can diagnose the answer. You can choose the answer. Okay. Young male having history of recurrent periapism usually resolve spontaneously, but this attack take longer time, lidocaine given, but no response. What is the next management step? So in any question in the exam, guys, in any question, check the problem, the presentation, because the presentation will give you the topic, okay? Whatever chest pain, whatever periapism, whatever palpitation. So check the presentation. This scenario talk about what? You have only one word in each question, okay? So here, what is the topic in this scenario, guys?
Sickler with periapism.
Periapism. Excellent. So here you are talking about periapism. If the patient has chest pain, you are talking about chest pain. If the patient has palpitation, you are talking about palpitation. So in any question, search for the presentation first. Okay, you will understand the question. After that, check what happened, what management done to the patient. So what management done here, guys?
Anesthesia.
Lidocaine was given.
Anesthesia.
Yeah.
Yes. So here in any periapism, so first of all, history, and then hydration for the patient means you will give fluids and analgesia because it's painful. Exercise, anesthesia. So it means history, hydration, analgesia, and exercise done already, right?
Yes.
Now the examiner said anesthesia done. It means what is the next action?
Aspiration. Aspiration.
What if he said in the scenario aspiration done? So what is the next action?
Injection.
This is how to think in the exam. It's not about memorize the management. You have to memorize the steps. Okay. So here regarding options, they said Corvosa cavernosa injection with phenylephrine. So it means injection. He's talking about the steps. He's talking about number 4.
Third step.
Yes. Ice compression. Do you see here ice compression?
No.
No.
Sir.
Okay. So aspirate blood with needle. What do you think?
This is the next step, sir.
Yes.
Correct.
Refer immediately to urology. So here lidocaine given. So what is the next step?
Aspiration.
Aspiration. Excellent. So we agree with this answer. Okay. Number 4, question number 4. Sickle cell anemia patient came with pain, shortness of breath. What is not included in management? So what is our topic in this question? What is the presentation?
Sickle cell anemia.
Excellent. Yeah, sickle cell anemia. Okay. So sickle cell anemia, it can present by different symptoms. Here, the most important symptom, chest.
Chest syndrome.
Yes, acute chest syndrome. So, what is the answer here, guys?
Corticosteroids. E.
Okay, corticosteroid. Excellent. Okay. So, what about bronchodilator? Can be given?
Yes.
Yes.
The acute
Decreases.
chest syndrome. Yes.
Bronchospasm, yes.
Okay. Antibiotic,
Yes.
Yes, sir.
fluids,
Yes.
Rehydration. Yes,
analgesia.
sir.
Yes.
Yes. Okay. So here the answer will be corticosteroid. Regarding sickle cell disease or crisis, you should be familiar with that. Okay. And general principles. So hydration, oxygenation, analgesia, antibiotic, identification, and the treatment of complications. Okay. 1 second, guys. Okay, so be familiar with the red flag. If you find in the scenario chest pain, saturation less 95, increased oxygen requirement, fever more than 38, increased work of breathing. So think about red flags. And also they can ask you which of the following considered as a red flag. Okay, so also consider start analgesia within how long, guys?
30 minutes.
30 minutes.
30 minutes.
15 minutes.
30 minutes here or 15, no problem. Okay, because it's a severe pain. Okay, so any patient with sickle cell crisis will present with a painful crisis. Okay, so in this topic, it's not about this question only. So study sickle cell disease and the crisis. Okay. So according to NICE guidelines 143, they said don't use corticosteroids in the management of an uncomplicated acute painful sickle cell episode. And here you can use nebulization because sometimes the patient presents with asthma. Also, you can treat the patient if he has chest pain. You can consider acute coronary syndrome or fat embolism. Sometimes hypoventilation because of pain. Sometimes he has bacteria or viral infection. Okay, so next question, number 5. A young male patient complain of chest pain and feeling worse when he is leaning forward or lying flat. History of viral illness and the drugs use. Patient febrile, what is the diagnosis?
Myocarditis.
They put MI, they put myocarditis, valve disease, they put rheumatic fever. What do you think, guys?
Myocarditis.
The clue
here, the clue is because leaning forward, there is a pain increasing. So it's going with pericarditis to myocarditis.
So antecedent viral illness is there, so it is myocarditis.
Yes.
Pericarditis will be relieved by leaning forward.
Yes, excellent. So here, of course, don't depend on this scenario because maybe it's not the same scenario in the exam. So you have to be familiar with the difference between myocarditis and pericarditis. Okay, so pericarditis, it will be sharp or pleuritic chest pain, worse in supine. Okay, pain radiating to the left trapezius bridge dyspnea. But here in myocarditis, they will mention flu-like, like myalgia, fatigue, fever. Okay, and most commonly in pediatrics. Okay, so we are talking about less than 18 years. Okay, granting retractions. So etiology here can be virus, can be also idiopathic, can be radiation, can be drugs. Diagnosis, clinical from the scenario. And here the ECG, the most important, check BR depression with ST elevation, check T wave inversion also. So ST elevation in most leads, except which leads, guys?
AVR.
AVR,
V1.
AVR and
V1.
V1.
excellent.
One.
So you will find ST elevation and BR depression in most leads except AVR and V1. Okay. If you find reciprocally changes, does it mean pericarditis?
No.
No.
So you think about
MI.
MI.
MI. Excellent. If you find any
Anesthetic.
reciprocally changes, it means the opposite. You find ST depression in, for example, inferior leads or something like that. So think about MI. So they can ask you also about ECG finding. They can ask you about management. So what is the management for pericarditis, guys?
Analgesics.
NSA.
NSAIDs.
Yes, ladies.
Yes, non-steroidal anti-inflammatory drugs. Excellent, very excellent. So when to do admission, guys?
When there is a fever,
Pleural effusion. If there's any pleural effusion, myocardial
Cardiac tamponade.
effusion,
Cardiac tamponade.
Excellent. So they can ask you directly in the exam, for example, which one of the following can be an indication to admit the patient? So think about that. It can be by different way. They can give you in the scenario features and these features for admission, and they will ask you what is the most appropriate management or next step. Okay, so if you find in the scenario effusion or you find temperature more than 38 or signs of myopericarditis, so this patient needs admission. Okay, and what about myocarditis, guys? What is the treatment?
Admit to monitored setting.
admission and cardiology center.
Okay, so this patient will be monitored but supportive, of course. Some people, they will need left ventricular assisted device or ECMO. Okay. Number 6, scenario about heat stroke. It's a common question in the exam. Patient hypotensive, confused, dilated pupils, and temperature 42. What is the appropriate management? So here in the exam, think about your task. They will give you scenario. What is your topic here, guys?
Heat stroke.
Heat stroke.
Heat stroke. Excellent. And what is your task?
Management. Appropriate
Not
management.
management. Appropriate management. Appropriate management. Okay. So there is difference between initial management or next step, or they will say appropriate management, or they will say most effective. Okay. So always check what exactly required in the scenario. Okay. So what is the initial treatment, guys, and what is the most effective treatment? What do you think?
We need to
Initial
lower down the
treatment.
temperature of this patient. So for that, we need
Initial treatment is to find an exposure.
If patient is stable, I mean, he is not hypotensive and he is not unconscious, we can give fan and exposure to cold water. But if patient, we can give immersion in the ice water. But if he is hypotensive, he is confused, or he is sick, then we have to just fan and expose the cold water, because we cannot immerse ice water if he is hypotensive and he is confused. We cannot immerse. We have to give them fan exposure to cold water.
I'm not agree with you.
No, because
No, no.
if patient is
Wait a minute.
critical, he's severe
It's
hypertension, you are going to
it's
put him in
asking
water?
about
No.
appropriate management. Appropriate management, what's the life saving you mean to do for the patient?
No,
The
see,
patient
I'm saying
unstable.
if
Yeah.
a patient
So are
is,
you waiting for the patient to respond to the IV fluid and things? Which one is the
no,
best?
see, if a
The
patient is
fast one to
critical, you
do.
are not going to put him in the bathtub. If you have to do the first ABCD, that time better it is to do cold water and fan rather than you will take him and put him in the water tub and immerse him. But if patient is stable enough, you can take him to the water tub. You can put him in the ice water immersion. But
Dear
if he is
doctor,
not
we are
stable
not
enough, so
leaving him all alone in the bathtub.
you cannot do other CPR or anything if you will put him in the
No,
water
no,
tub.
no. Actually, basically, appropriate management would be like we don't have to leave him all alone in the tub. We have to keep an eye on him. But
So it depends.
this would
Yeah, I agree
this
with you,
would
but it depends
actually
on the stability. Yeah, I
this would
agree with you.
actually raise his blood pressure also. We can put him in the, and then there is a peripheral resistance with the cold water.
Okay,
Even get
guys,
the pressure
thank
back.
you.
Yeah,
Thank you,
that
Let
guys.
Dr. Hani talk.
Thank you, guys. Okay.
Dr.
So
Hani, please.
here the patient is hypotensive. Of course, he did not give you option for resuscitation here. He did not give option for resuscitation. So it's not the point of resuscitation. If you find, for example, cold IV fluid, of course, we will choose cold IV fluid. Okay. But here he is talking about dantrolene or immersion in ice water or fan and exposure. So he is talking about control of temperature, right? He's not talking about stability of the patient. Okay. So anyway, he is talking in general now. What is the appropriate management? So if he will say what is the initial management, I will choose fan and exposure to cold weather. Okay. So because not all hospitals or not all emergency physician will do immersion, right? In ice
Yes.
water,
Yes.
of course. So initial, it means the usual. Initial, it means the usual. But this patient, appropriate management, even if not done by all emergency physicians.
management depends on the stability of it, whether the patient is stable or unstable. So this two B and C option depends on how patient is stable or not.
Yes,
So we can
excellent,
run
excellent.
that.
We have to consider because immersion in ice water and the cooling sometimes need the patient to be conscious and stable.
Excuse me, sir. As for the new guidelines, we have active this management and passive management. So it really depends upon the stats of the patient. The active management is the management that's done by us. Passive management is the management that's done by the patient itself. So if the patient is confused, it means he cannot do passive management. So it is to be done by us.
Wallahi, I just thought of
First
you now
thing is
before you
hello,
came.
Yes,
Hello?
yes,
hello.
yes, we can hear you.
Yeah, they as per the new guidelines, we have to put the ice packs at the three main areas where there are big veins. There's carotid areas, axillary area, and groin regions. These are the first three major. They had taken the dantrolene out of this guidelines now.
Yeah. So you will go for dantrolene or immersion or fan and exposure, guys.
Not entering for
We
sure.
will start with
Immersion
simple
is
measures.
Can I speak, please? Excuse me. I read it in the RCM clinic. It says in any head stroke with life-threatening conditions, the best treatment is immersion. Gold standard. It's saying like that. Briefly. So I'm going with B.
Dr. Hani,
Yeah,
can you hear me?
yeah.
In success reference, we read already for stable patient, we will do immersion. But new guideline in MRCEM say for unstable patient, need to immersion.
Okay. For me, I will go for fan and exposure to cold weather. Okay, and if they said, for example, what is the most effective management, so I will go for immersion in ice water and cooling. Okay, if the patient they mentioned conscious and stable, so you can go for fan and exposure. But if you feel in the scenario in the exam he's talking in general, so you can choose immersion. If he's talking in general, what is the most effective or what is the most appropriate management in general, so you can go for immersion in ice water and cooling. So anyway, guys, in any scenario, it's not about this question, I'm talking in general. For example, patient with chest pain, what is the initial investigation?
ECG.
ECG. What is the definitive treatment?
BCI.
BCI. What is the definitive investigation?
PCI.
BCI.
Angiography. Okay. So yeah. So here the most important, understand the question. What does he need exactly? He needs initial investigation or he needs in definitive investigation. Okay. And also management, initial management or definitive or appropriate management, and so on. Okay. So we can go to the next question.
Excuse me, for this question, if the patient is not stable, I mean confused, so can we do the immersion in a cold water?
Yes, but here he did not say what is the next management. Okay, so if he said what is the next management or next step, so you can
Please
check the
mute
scenario.
your mouth.
Because I read that if the patient is not stable, I mean, like in this case, hypertensive, confused, then immersion in ice water we should not do it, and she should be fan and exposed to cold weather. So that's why I'm a little confused.
Yeah. And according to Arkham Learning, they said there are lots of ways to cool the hot patient. Spraying the patient with tepid water and using a fan is the most practical method. Okay. Immersion the patient limbs or whole body in cold water is described but impractical. This according to Arkham Learning. So in a way, guys, the most important, check the scenario well, if the patient is conscious or not, stable or not, and also if he asks initial step or if he asks about most effective or most appropriate. Okay.
Okay, because I just joined. So for this question, the answer is immersion in cold water.
This is not my answer in a way. This answer of the one who compiled the recall, guys. Okay. Now we are checking this answer are correct or not. Clear?
Yes.
Okay. So if you said here appropriate management, you can go for immersion. If he said what is the most effective management, what is the management to decrease temperature rapidly, so you think about immersion in ice water. But if you feel in the scenario he is talking about the presentation for this patient, so you can check stable or not, conscious or not. Clear, guys?
Okay.
If he said what is the initial management, so you can think about fan and exposure to cold weather. Okay, anyway, next question, scenario about patient need muscle relaxation agent for procedure. He mentioned succinylcholine. Okay, so why not to give him? He means patient why contraindicated for succinylcholine. He means that. So what do you think, guys?
Hyperkalemia.
Hyperkalemia.
Oh, malignant hyperthermia.
So me also, I agree with hyperkalemia. So succinylcholine, it's very common in any exam. So think about that. They can ask you also about hyperkalemia and how to avoid that. Okay. And hyperkalemia, it's a very, very important topic in the exam. So some people, they said, they mention in the scenario, in the options, pseudocholinesterase deficiency. So what do you think, guys?
So the last one will be correct.
This succinylcholine will act on the cholinesterase enzyme.
There will be
so-
malignant hyperthermia if there is say the cholinesterase deficiency.
Yes. So here, if they give you options without pseudocholinesterase, you can choose hyperkalemia. But if they put pseudocholinesterase deficiency, so which one to use? Hyperkalemia or pseudocholinesterase deficiency?
Deficiency.
Deficiency.
Efficiency. Okay, excellent. So this is what I need from you guys. Don't memorize the answer or don't memorize the question. So sometimes they will.
Just a question, Dr. Hani.
Yeah.
Pseudocholinesterase deficiency, I think it is not a contraindication, or hyperkalemia is a side effect, right?
Hyperkalemia may be mild. It is very less.
Hyperkalemia is side effect and contraindication.
Pseudocholinesterase is a contraindication. But
Contraindication, yes.
I think hyperkalemia is something gives sense because not you don't know as a doctor your patient that he's pseudocholinesterase deficiency or not. Is it possible to know that?
Yeah, but here he is talking in general. He did not say about this patient. Okay, so he give you some options to contraindication of succinylcholine. Okay, so sometimes the examiner is talking in general. It doesn't mean in this patient. Okay, so contraindication of succinylcholine, whatever hyperkalemia, hyperthermia, renal impairment, he is not talking about this patient specifically. Okay, so according to the BNF, here contraindication for succinylcholine, hypersensitivity to active substance or any personal or family history of malignant hyperthermia. Remember that. Inherited atypical plasma cholinesterase activity, our option. Okay. Also, abnormal plasma pseudocholinesterase activity. Hyperkalemia after that. Clear, guys? Hyperkalemia from any cause. This is the last option. Also, remember that muscular dystrophy. Okay. So, muscular dystrophy and the other myopathies. So, if they give you option from these options, so you can choose. Okay, guys? So, malignant hyperthermia before hyperkalemia, right?
Yes.
Okay. So, if the patient has malignant hyperthermia, you can choose. But here he said hyperthermia, not malignant hyperthermia, right?
Yes.
Okay. So, again, guys, it's not about to study the question. I want you to study the topic. I want you to read about succinylcholine. Okay? The dose, how to reverse. Anyone has idea about how to reverse?
Reverse what?
No reversible, no?
No reversible is there, but we can try.
No reversible agent.
Okay.
Because it is short acting.
That for recronium, but not for succinylcholine.
Okay, excellent.
Fear stigma can reverse by fear stigma.
So, how long the action for succinylcholine?
Short acting, it is 3 minutes.
10 to 20 minutes, 10 to 20 seconds.
Second.
Again, after some time.
It's a short duration. So if the patient difficult ventilation or difficult intubation, you can do back valve mask until the patient awake, right? Okay. Patient admission in ICU for local anesthetic toxicity. It means he was in local anesthetic toxicity after that admitted in ICU. He means that What is the suspected complication after many days? It means long-term complication. What do you think, guys?
Pancreatitis.
What do you think about pancreatitis?
The patient is admitted, so already he received intralipid.
Yeah, intralipid.
So this is the side effects of the contral effect that will cause pancreatitis.
Yes, excellent. So here, regarding any other complication, it can be direct or fast, but he is talking about after many days. It means a long-term complication. So it's obvious for pancreatitis. So this patient already he has local anesthetic toxicity because of what? Lidocaine, for example. Okay, and after that, given intralipid. One of the common complication of intralipid is pancreatitis. That's why any patient with intralipid should be admitted in ICU. And here you have to check intralipid complication daily. You have to review the patient daily in ICU. So you should be familiar with lidocaine, brolocaine, and bupivacaine, and be familiar with the use. Okay, so lidocaine for local infiltration, brolocaine in Perze block, bupivacaine in fascia iliaca block. So again, don't study the question only, study the related topics, expected questions. Okay, and also be familiar with the onset. They can ask you about the onset. They can ask you about the duration. Which is the longest one, guys?
bupivacaine.
Okay, so be familiar with the maximum dose with or without adrenaline. Okay, guys. Again, please study the relevant questions, the relevant topics.
Dr. Hani, I have a question, please.
Yes.
When a patient have a toxicity for local anesthesia, and the patient have the arrhythmia, as it have this systemic lidocaine because of the toxicity. So you will give intralipid first, or you will go for the DC first?
So you mean the patient has local anesthetic toxicity and he has arrhythmia?
Yes. If it's ABCD going, we should go DC, I think. Am I right or not?
Yes, any patient with arrhythmia, you have to go for ABCDE. So if airway patent and the breathing normal, inspection, palpation, percussion, auscultation, and you are in C now, right? You mean you are in C. So the patient on the monitor arrhythmia, you have to check first. This arrhythmia is,
let's say it's VF,
stable or unstable. Okay. So if the patient is unstable, what do you think, guys? Arrhythmia and unstable.
ABC first.
DC shock. DC shock. Okay. Synchronized DC shock. Excellent. If the patient is stable and the arrhythmia, you have to follow the algorithm for tachyarrhythmia.
Yes.
Okay. In the meanwhile, give intralipid fluid and intralipid. So oxygen, fluids, intralipid. But you have to follow the algorithm of tachyarrhythmia, whatever, narrow or wide complex.
Yes.
Okay. And so on.
Thank you.
Welcome. Also, be familiar with methemoglobinemia. So the patient given local anesthetic toxicity, after that, he has symptoms and the signs of methemoglobinemia. Okay, so they can ask you what is the diagnosis. So you will choose methemoglobinemia, and also they can ask you which local anesthetic given. So which one you will choose, guys? They can ask you about the dose. How much dose given to the patient expected?
16. Okay.
More than 16 milligram per kilogram. So again, it's not about studying the question. You have to study the relevant questions. Okay. So here, how to diagnose? Patient given local anesthesia. After that, he has cyanosis and he has signs of methemoglobinemia. How to diagnose?
ABG.
ABG for
Hemoglobin.
hemoglobin level. Excellent. And what is the treatment?
Methylene blue.
Okay. What is the contraindication for your treatment?
G6PD.
Vitamin C.
Okay. So this is how to study, guys. This is how to expect the scenarios. This is how to expect the option.
Hemoglobin M also. Hemoglobin M.
Okay. So they can ask you when to start the treatment.
Methemoglobin more than 20.
Excellent.
If symptomatic. More than
Symptomatic.
30 if asymptomatic.
Excellent. So this can be expected question as well, guys. Okay, so be familiar with local anesthesia. How to decrease the side effects, guys, or complication or toxicity? How to avoid that?
Correct calculation.
Accurate dosing.
Excellent.
Yeah, and
Proper use of injection.
aspiration every time when you're pushing the local
Excellent.
anesthesia. Yeah, decreasing the dose in the elderly.
If available, ultrasound use.
Ultrasound guideline.
And use adrenaline is better than non-adrenaline.
Okay, excellent. So number one, the most important, accurate calculate dose of adrenaline of local anesthesia, and number two, also regular aspiration and the slow injection. Also decrease the dose in extremes of age of frail patient. Okay, so here you have to stop. Number one, stop the local anesthesia. Stop the local anesthesia. Number two, oxygen, fluids, and if the patient is collapsed in the scenario, whatever hypotensive or unconscious or arrest, so you can consider intralipids. So you will give 15 ml per kilogram per hour infusion. Okay. And regarding pancreatitis, if the patient is admitted, you have to exclude pancreatitis by regular clinical review daily. You will check amylase, lipase. So this one can be different way of the same question. So what will you do? So you can check amylase, lipase daily, okay, for 2 days. Okay, next question. Young female came to ER complaining of generalized fatigue and dizziness, history separation from her husband 3 months ago, according to sad person score. What is the cause of her symptom? What do you think, guys?
Separation and divorce.
So the diagnosis here can be depression, but the cause here may be
separation and divorce.
Yes. So he did not ask about the diagnosis. Depression is a diagnosis. So how to diagnose depression? More than 2 weeks, persistent sadness or persistent symptoms. 4 or 5 symptoms for more than 2 weeks. So whatever low mood, low energy, change in appetite, change in sex drive, okay, anhedonia. So they can ask you about these things. So it's not about to study this question. Be familiar with the risk factors. So sad person's score. And also they can ask you which of the following risk factors can score 2. So D, R, O, S. Remember that, guys. They can ask you which of the following can score 2. So depression or hopelessness, rational thinking loss, organized or serious attempt, stated future intent. So what does it mean, rational thinking loss, guys? Anyone has idea?
Thinking about he want to die, he want to live, he don't want to live.
Okay, rational thinking loss, it means psychosis or thought disorder. The patient has psychosis in the scenario. For example, they can see, hear, smell or touch, which is not there. The patient can smell or hear someone or see something or feel someone or something touching him. So here we are talking about psychosis. Or maybe he has a
Like
thought
mania?
disorder.
Hallucination, like
Not mania.
Hallucination? Okay.
Not mania. Depression, it means persistent sadness more than 2 weeks. Okay, but mania is the opposite. Persistent happiness. The patient has high mood. High mood. Okay, the opposite here. The third diagnosis, we finished depression, we finished mania. The third diagnosis is psychosis or schizophrenia. So schizophrenia or psychosis, the patient has symptoms of psychosis, as we said. Here, smell, see, or touch.
But the rational thinking, doctor, excuse me, the rational thinking loss is not about like hallucination, auditory or smell or visually. It's about the patient is being unable to express his belief or agreeing or disagreeing on a logical basis.
Yes,
So
this will you will find with patient with psychosis and thought disorder. That's why they make connection between rational thinking loss and psychosis and thought disorder. Clear?
Yeah, so it's the modified scale, yeah.
Yeah. Okay. So in a way, don't confuse yourself. They will not ask you about this. They will ask you about factors, any factor, and most likely they will ask you about the score 2, so DROS, and most likely they will ask you about, for example, the score of this patient, so you can calculate. Also, they can ask you about.
Excuse me, what is the cut point for sad person? So we can see this is a depression.
Yes, they can ask you about this one. Excellent. So when to save discharge the patient, they can ask you about that. When to do psychiatric assessment, when to do admission. So any idea, guys, about when to save discharge the patient?
I think it's 6 or below. To be saved, 6 or below.
The score less than 6, we can discharge the patient.
Okay, you can discharge or save to be discharged.
Safe
to be discharged.
6 to 8, you have to be psychiatrist.
It means it's better to do psychiatric assessment. So any patient scored low, you can do psychiatric assessment. So if the patient has depression and also, for example, excessive alcohol or drug, and you score his score 4, you will discharge him or you will do psychiatric assessment.
Discharge.
No, psychiatric assessment. Psychiatric assessment. But if he said, no, I don't want, so you can assess his capacity and you can discharge him. It means it's safe to him to be discharged. Clear, guys?
Yes.
Okay. So if he want to be discharged, no problem. You can discharge. If he insists, but do your best to be assessed by psychiatrist. Okay, patient has depression. How we will discharge? No, but if he insists, it's safe to be discharged. Anyway, just remember when to be safe to be discharged and when to do psychiatric assessment and when to do admission. Okay. Number 10, scenario about Somalia child. Patient complain of dysuria. On examination, there is blood in underwear and the loss of eye contact. What is the diagnosis? What do you think, you guys?
Female genital mutilation.
Female
Maybe
genital
anal
mutilation.
fissure. Maybe anal fissure. Maybe it is hemorrhoids.
Yeah.
Maybe, but loss of eye contact is going more with this.
Sexual abuse.
Definitely.
Female genital mutilation.
In the underwear,
FGM.
Okay, so
we should concentrate on the region Somalia and كده. This is
excellent. Excellent. Okay. So we have UTI here. If you have confusion in any question, you can rule out other options. For example, UTI. Do you think it's a UTI?
Oh.
No.
It can be, but the patient, you will not find blood. You will not find loss of eye contact. Okay. So dysuria here may be UTI. Okay. Genital trauma, it can be, but the patient, you will not find loss of eye contact, right?
Yes.
Yes.
Dysuria here, it's infection. Infection may be trauma, genital trauma. After that, she has infection. Maybe sexual abuse, maybe female genital mutilation. Okay. So
I think it's sexual abuse.
yes, we have dysuria, we have blood in underwear, we have loss of eye contact. We have three features in the scenario. All of them can be female genital mutilation, can be sexual abuse. Okay, guys? But Somalia here going with
Female genital
mutilation.
traditional.
okay, clear, guys?
Yeah, clear.
Okay, so don't say sexual abuse because of loss of eye contact. No, it can be because of female genital mutilation also. Okay, so anyway, this option, it's common, whatever in SBA2 format or SBA format. So I will go for female genital mutilation because of Somalia. Why they mentioned Somalia? For a reason, right?
Yeah.
Okay. Patient came with history of glandular fever. So history of glandular fever here, is it present history or past history?
Past
history. Past.
So if I will say patient has history of liver disease, it means he has today or he has the past history?
Past history.
Because if he will say today, he will say suspected glandular fever, right?
Yes.
But here we don't know. Maybe the one who compiled the recall, maybe he is not sure. So be ready for any possibility in the exam, guys. Okay. And the abdominal pain. What does it mean, abdominal
Dr.
pain?
Hani,
Yes.
maybe he means that he is known to have glandular fever.
Yes. What we say, he has history of glandular fever. It means he has glandular fever confirmed. Okay.
Yes.
Confirmed now. Otherwise, he will say suspected glandular fever. Right, guys?
Yes.
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 Okay. So here, check in the scenario if suspected or confirmed glandular fever. And abdominal pain. So glandular fever, we are talking about infectious mononucleosis. It's a different name for infectious mononucleosis. So regarding abdominal pain, what is the reason behind that?
Splenomegaly.
Hepatosplenomegaly.
Splenomegaly, it will cause abdominal pain or what?
Splenic rupture.
Splenic rupture. Excellent. Any patient with glandular fever or infectious mononucleosis, it can cause splenomegaly. But if the patient has abdominal pain, it means he has rupture. Right?
Yes.
So what's the test of confirmation the diagnosis? So diagnosis here for glandular fever or abdominal pain?
Abdominal pain.
Abdominal pain.
Until now,
because he gives the diagnosis already.
Yes, if according to this scenario, if he said history of glandular fever, it means diagnosed already, right?
Yes.
But be sure this formulation, it's not accurate. So check in the scenario in the exam. Okay, he mean test of confirmation, the diagnosis, he mean glandular fever or splenic rupture. Okay, guys?
Yes.
Okay, so what is the confirmation for glandular fever? What is the confirmation for splenic rupture? What do you say?
According to, for glandular fever, according to the age and presentation within 2 weeks.
Excellent. Okay. So here he answered without age. Can you answer without age?
I can't.
You cannot. Okay.
Already finished then, glandular fever.
Yes. So here regarding glandular fever, so you have to check the age. I'm talking now if he asks about confirmation or diagnosis of glandular fever. Okay. So if less than 12 years and the patient immunocompromised, so you can do serology, viral serology. It means you will check for the virus. Which virus, guys?
Epstein-Barr virus.
Yes, it can be another question. They can ask you in the exam. Which is the causative organism for this disease? So they can give you this image. They can ask you what is the diagnosis. If they give you infectious mononucleosis, you can choose. If they give you glandular fever, you can choose. If they give you what is the causative organism, Epstein-Barr virus, okay, the most common. And if they ask you about the diagnosis, check the age first. Less than 12, it will be serology. It means you will check for the virus. If more than 12, what will you do?
Differential with
monospot. And the full blood count.
Full blood count, yes.
What's different? Okay.
In the second week of the illness.
Okay. So if they ask you about the complication here, so develop abdominal pain may indicate what?
Splenic rupture.
Splenic rupture. Splenic rupture.
Yes. It doesn't mean hepatosplenomegaly. Okay.
Yes, yes.
Okay. Because the patient maybe he has splenomegaly but no pain. Okay. But if he present after 2 days, for example, you diagnosed him. For example, you did his age more than 12. You did monospot test and now diagnosed with glandular fever. After 2 days, he came back with abdominal pain. Did you understand the scenario?
Yes.
Yes.
Okay. Yes. So please again, in the scenario in the exam, be sure he's asking about diagnosis for what? For glandular fever or for the splenic rupture. Okay? Clear, guys?
Yes.
Okay, thank you. Can go to the next question. So regarding splenic rupture, if the patient is stable, you will choose what?
CT.
Or
contrast.
CT with contrast. Or ultrasound. Both of them accepted if the patient is stable. But if the patient unstable, you will choose
Ultrasound.
ultrasound. Don't do CT scan for any patient who is unstable. But if the patient is stable, you can choose anyone available in the scenario. Scenario about heart score. So you have to be familiar with heart score, which is not included in a score. So what do you think?
Stroke.
Stroke.
Okay. So here stroke, it's not involved, right?
Yes.
Okay. So heart score, it means we are talking about HEART. So history, also ECG, age, risk factor, troponin. Okay. Okay. So be familiar with the score 2. 2, it means highly suspicious. What does it mean, highly suspicious, guys? Any idea?
Typical chest pain.
Typical chest pain. Started
So
pain.
it means the patient has symptoms in the scenario for ACS, right?
Yes.
Typical.
Yes. Okay. So if you find any scenario in the exam with symptoms of ACS, acute coronary syndrome, it means 2. ECG, significant ST depression, it will be
2.
2. Age more than or equal 65 in the scenario, it will be
2.
Risk factors equal or more than 3 risk factors, or history of coronary artery disease. So if the patient has coronary artery disease, past history, it means it's a 2 also. Okay. Troponin here, can you depend on troponin or no need? Is it important?
It's important.
Yes.
Important, but is it mandatory?
Sometimes
No. Not mandatory. Why?
Unstable
Yes.
angina patients are also not having regular.
Yes, because
raised
a score of 7 to 10, you will do invasive strategy. So this patient needs a BCI. So 7 enough. So if the patient has history, 2, patient ECG 2, now 4, age 6, risk factor 8. So troponin negative, but other HEAR 8. So what you will do?
PCR.
Still will go.
Even troponin negative, right?
Yes.
Yes. Okay. The next question is succinylcholine. They said cause prolonged paralysis by what mechanism? Here, he did not formulate question, but anyway, you can expect any question for succinylcholine. So they can give you option here, depolarizing or non-depolarizing muscle relaxant, also NMDA. Also, they can give you option GABA. Okay. So here regarding cholinesterase inhibitor, it can be an option. So if you find, you can choose. Be familiar with succinylcholine mechanism and rocuronium also mechanism. Okay. So succinylcholine, it's a cholinesterase inhibitor, acetylcholinesterase inhibitor, work by blocking the action of acetylcholine on skeletal muscles. It's a depolarizing also. So if you find anyone, you can choose. What about rocuronium? Act by competing for cholinergic receptors at motor end plate. This action is antagonized by acetylcholinesterase inhibitor. Antagonized here, it doesn't mean the antidote. So you can use nostagmin, you can use idurfonium. You can also use Sogamadex. Okay. So the most common and the important is Sogamadex. Okay. So here the action of rocuronium, it can be 30 to 40 minutes. If you cannot intubate the patient or ventilate the patient will die. Okay. Or you have to go for a surgical airway. Okay. So Sogamadex here, it's a very, very important. Also, they can give you option non-depolarizing muscle relaxant. So if you are familiar with that, you can choose. Next question, 12 years, boy came with severe testicular pain and had similar attack before and resolved spontaneously. So I think it's obvious for testicular torsion until now. Any patient with testicular pain, it's a testicular torsion until proven otherwise. Doppler done and diagnosed as testicular torsion. What is the most common cause? Do you agree with Bell-Kleber congenital deformity?
Yes.
Okay, me also, I agree. So they can ask you about the signs. They can ask you about the symptoms. For example, they can give you this scenario. They can ask you which of the following signs you can find on examination to support the diagnosis.
Absent.
So what do you expect, guys?
Absent.
Which one?
Premasteric reflex.
And positive angle sign.
Friends
Okay,
test.
excellent. So cremasteric reflex and
Horizontal
also
lines.
brain sign. So be familiar with examination of testicular torsion. They can ask you about that. And what is the initial investigation?
Ultrasound.
Doppler ultrasound.
Doppler ultrasound, excellent. For one testis or both?
Both.
Both. Okay.
You find
And
why
what is the definitive investigation?
surgery.
Exploration.
Excellent. Surgical exploration. Excellent. Okay. And what is the definitive treatment?
Also
Exploration and untwisting.
Surgical exploration,
Untorsion
total
and
exploration, and untwisting. So the same as investigation, definitive investigation, but you will add untwisting of the testis. Okay. And what is the limit time?
6 hours.
4 to 6.
6 hours. 6 hours.
6 hours. Excellent. Okay. So this one, Bill Kleber defined. Okay. Next question. I think it's wrong ECG. And also maybe not the same scenario, not formulated well, but anyway, scenario about broad complex tachycardia. So they will give you ECG with broad complex tachycardia. He said here, and VT, what is the difference between VT and SVT with aberrancy? I think that the formulation not like that, okay? They give option for right bundle branch block, fused B wave. Anyway, what is the diagnosis in this ECG, guys?
SVT because narrow complex.
Okay, so
There is RBB. RBB with the left axis deviation.
No, if LED is not there.
There is
LBB. It's not RBB.
This is LBB.
LBB, sorry, LBB.
Deviation
LBB.
left.
Right axis deviation is.
Yeah, left axis deviation and left bundle branch block.
Left bundle branch block with tachycardia.
okay, so this one left axis deviation. How to check the axis? Lead 1 and lead 3.
Yes.
Lead 1 and lead 3. So it's a left axis deviation. And if you see left axis deviation, it will confirm it's a left bundle branch block, right?
Yes.
There's
If you
also left
find-
ventricular. There's also left ventricular strain.
This one, it's a left bundle branch block. If you find S dominant in V1, it means it's left. If you find the R dominant in V1, it means we are talking about right bundle branch. Okay, like this ECG, guys. This one, left or right?
Yes, right.
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 Okay. So here, if you find RSR or M shaped in V1, it's right bundle branch. So anyway, here he did not check the ECG well. Anyway, so I formulated the question. I said a patient presented with palpitation, was collapsed at home, and now all observations are normal. What criteria in the ECG to differentiate between VT and SVT with aberrancy? It means, what is the diagnosis in this ECG? Sorry, this one. What is the diagnosis in this ECG? Let you to think about SVT. Clear, guys?
Yes.
Yes.
Yeah.
Yes.
So it's unlikely to find VT with aberrancy, right? Unlikely to find VT with bundle branch block. So if you find the bundle branch block, it's going with VT or SVT?
SVT with aberrancy.
Yes, excellent. This is the meaning of the question. Okay. So
actually his question is, what is the difference between VT and SVT with aberration conduction? So that means he must have difference between VT and SVT with bundle branch block. That's what the question is asking.
I said, doctor, please listen to me. I said this formulation, it's not correct. Okay. So here, if he said, what is the difference between SVT, where the question, this one. If he said, what is the difference between SVT and VT? So you have to think about the criteria in general in the ECG, okay? This is your point.
Because there is a fusion beat, escape beat, and there's a difference, around 10 difference between VTEC and SVT with aberrancy. There are the different points. So maybe the question is asking that thing.
Yes. If they ask clearly, what is the difference between VT and SVT with aberrancy, so you should be familiar with the criteria, okay? But unlikely in the exam to ask you about this question, okay? They can ask you what is the criteria in this ECG to differentiate between VT and SVT, okay? So be familiar with right bundle branch block, be familiar with left bundle branch block, also atrial fibrillation, Wolff-Parkinson-White syndrome, atrial fibrillation, okay? So Wolff-Parkinson, what is the criteria in the ECG?
Delta waves.
Delta wave.
Delta wave and
wide QRS complex.
Short PR. Short PR interval.
Okay.
No delta wave.
So Wolff-Parkinson-White syndrome, it will be short BR, it will be delta wave, it will be wide QRS, right?
Yes.
Atrial fibrillation will be irregular. Okay. Atrial flutter, it will be like okay. So right bundle branch block or left bundle branch block, just be familiar with this one will be left and this one will be right. Okay. And again, if they ask you clearly like this scenario, what is the difference between VT and SVT with aberrancy? So check the criteria to differentiate between them. Okay. After this session, you can check how to differentiate between VT and SVT, the criteria in the ECG. Okay. And I will share in the group. After the session.
Thank you very much.
Okay.
Thank you, sir.
Okay. Scenario about baby had neonatal sepsis. How to take the sample? So here it's not sure about how to take the sample itself or how to take the sample means the source of sample. It will be clear in the exam chart. Okay. So what do you think, guys? This answer is correct?
Maybe not. We're confusing with this question.
According to the small scenario, it's the logic one, but not correct 100%.
But I think the amount of sample should be more than 1 cc.
Yes, the logic one.
Do you think he's asking about the amount?
No.
No, this is a neonatal sepsis. We need to do culture.
Why we have to talk about the amount? I think any amount of a sample, it will be very tough to do the culture.
Yes. Okay.
Culture, for culture you don't need a large amount of sample, I think.
Also, the amount of sample, it's not our duty, right?
Yes.
If you will request for the sample for culture or sample for microscopy or sample for any sample, so the duty of the nurse, she will check the amount, right?
Yes.
Okay. So what do you think? What do you think? What is the answer?
Sepsis. So we should take a culture.
Culture.
Most important.
We will order for the culture to do.
Me also.
Yes.
Yeah. Me also. I will go for culture, whatever from both sides or not. It's not about issue. So culture.
Well, my question is that in mostly this children pediatric scenario, most of the patient which has like red flag features or the intermediate, most of time we refer, and in ED we do not manage this kind of patient. So why we should, in a nice guideline said we have to send only urine sample, but for this kind of thing, it's confusing totally.
Okay. So
because in ED we do not manage this kind of patient, especially. I think these patients need referred to pediatrics and they have to send the blood test or culture, anything like that.
okay, so here neonatal sepsis, according to the guidelines, NICE guidelines, they defined the neonatal sepsis early and late onset infection, early onset and late onset. So the difference between early onset and late onset, it will be features of sepsis within 72 hours of life, this early. So it's not a matter early or late, but just be familiar with that. And if the features after 72 hours of life, it's late onset sepsis. Both of them, they recommend number 1, blood culture, number 2, CRP, number 3, lumbar puncture. Okay, so we will check the guidelines, always depend on guidelines. So first, we are talking about first 72 hours. When starting antibiotic treatment in babies who may have early onset neonatal infection, so perform what, guys?
Blood culture.
Blood culture.
Blood culture. Did they talk about the sample? No.
Only blood culture order, yeah.
Okay, perform a blood culture. If the blood sample is, if the amount of the sample is important, they will mention, right?
Yes.
Okay, so perform a blood culture before giving the first dose. Measure baseline CRP when starting antibiotic treatment in babies who may have early onset neonatal infection. If it is safe to do so, perform what?
Lumbar puncture.
Lumbar puncture to obtain CSF sample. Okay, number
3.
3. Number 1 is blood culture. Okay, so when to do CSF, guys? If there is a strong, it can be another question. A strong clinical suspicion of early onset neonatal infection, clinical symptoms or signs suggesting meningitis. So they can ask you when to do lumbar puncture. So if the patient has clinical suspicion or symptom signs of
meningitis.
So in this case, it will be number?
Yes, lumbar will be first.
Okay, so blood culture is the first one. If you have indication to do lumbar puncture, it will be number 3. Okay. Don't routinely perform urine microscopy or culture. Don't. Okay, so don't choose urine microscope. Okay, so don't use as a routine. Don't perform a skin swab microscopy or culture as part of investigation. So the same in early onset infection, same as late onset infection, same. Number 1 is
blood culture.
Number 2,
Yes, injective protein.
CRP. Number 3,
lumbar puncture.
When to do lumbar puncture?
Clinical suspicion of meningitis.
I think now clear.
Yes.
Okay, so blood culture, CRP, lumbar puncture. Okay. So I will go for blood culture.
Is it
next?
Sorry.
Yes.
Is it possible to ask about the causative organisms regarding the early onset and the late onset?
Yes, it can be. Okay. So regarding the guidelines, I will send in the group also. Okay. Early and late, it will be in one PDF for the NICE guidelines. Okay.
Thank you.
Welcome. So this X-ray, if you find ECG in the exam, if you find X-ray, if you find image, number 1, check the image or X-ray or ECG or ABG. Okay, guys?
Yes.
Yes.
So if you find lab results, if you find ABG, if you find ECG, if you find X-ray, okay, in the exam, number 1, go for them. Why? Because it will give you idea clearly and quickly. So what do you think regarding this X-ray?
In addition,
Air fluid level.
in
Air
addition
fluid
to
level in the
In
chest,
the
left
in
side.
the lung. Yes.
Excellent.
Yes.
Okay. So I wish you guys, if you are studying, search in Google by the name of the diagnosis. So for example, congenital diaphragmatic hernia. You can search by congenital diaphragmatic hernia and search by images. You can write X-ray, congenital diaphragmatic hernia X-ray, and search by images. They will give you all images because in the exam, they will choose one of these images in Google. Okay, so maybe you are familiar with this X-ray, but if I will give you another X-ray for congenital diaphragmatic hernia, you will not diagnose. Clear, guys?
Yes.
Okay. So he said here 4 days. He said 4 days. If you find the 4 days in the exam, he's talking about congenital until proven otherwise. Maybe congenital diaphragmatic hernia, maybe congenital lung problem, maybe congenital heart disease. Okay. So any days in the exam, 2 days, 3 days, 4 days. So he's talking about congenital because diagnosed early. Okay. So 4 days, baby distress after feeding. What is the diagnosis? So I think you agree with diaphragmatic hernia.
Yes.
Okay. Congenital heart disease, do you think they will give you X-ray?
No.
It's unlikely.
Yes.
Perforation viscous, do you think they will give you complete chest X-ray?
No. Abdomen X-ray.
Unlikely. So perforation viscous, if they will give you X-ray for chest, it will be without the head, right?
Yes. With abdomen.
At least it will be chest and abdomen, but not head and the chest. Okay.
Okay, sir.
So diaphragmatic hernia. Okay. Next, what do you think regarding the X-ray?
Foreign body, opaque.
Radio opaque.
Yes,
Fine.
excellent. We cannot say foreign body. We don't know. Okay. So you can say radio opaque shadow. Radio opaque shadow. Okay. So here, if they ask you what is the most likely diagnosis, you can say foreign body. But if he said, what is the finding? What is the finding, guys?
Radio big shadow.
Radio big shadow. Okay. So the finding different than the diagnosis. The diagnosis also it's not confirmed. So he will tell you what is the most likely diagnosis because it's not confirmed yet. Okay. So here they give you abdomen or chest.
Abdomen and chest.
Abdomen. Even the chest is not clear. So he's focusing on the abdomen, right?
Yes.
This is what I mean in the previous one. So can you see the head here?
Yes.
Because focus on the
chest.
Chest. Okay. So how to understand the problem in the exam? Check is focusing on what? Okay. So anyway, of course he mentioned here magnet battery, but maybe in the exam he will not mention. Okay. You will understand it's a magnet. Okay. So what do you think?
How I know this is magnet or battery or whatever
Yes.
point?
Yes. Here, whatever battery or magnet it will be the same. The same. Okay. This patient, you will discharge or admission. Discharge home with advice. Admission for observation. Discharge home with advice. Admission for observation. Refer to pediatric. Refer or prepare for laparotomy operation. What do you think?
Laboratory operation.
I think it's a magnet because it's all clustered together. If it was a battery, they will not be inducted together.
Excellent. Okay. So always magnet, it will stick together. And this is the pathophysiology. One magnet will be in one bowel and the other magnet will be in different bowel, and they will stick bowels together. Can you imagine, guys?
Yeah.
So this is the
Yes.
causing obstruction.
So
It's
this
called
will
obstruction and
cause-
strangulation.
Yes. So this will cause obstruction, will cause necrosis, will cause ischemia. After that, perforation. After that, bleeding. Of course, painful. Okay. So this one, is it safe to be discharged?
No.
No.
No way.
No way. But if coin only, if they mention coin clearly in the scenario and it's one, no problem. You can discharge home with advice, right?
Yes.
Okay.
But if it's below stomach, then it's safe.
Excellent.
If it's in the chest,
So
yes.
yes,
For the coin.
we are talking about the coin. Okay. Here we are talking about magnet or battery. So the most important check, is it in the stomach or below the stomach here?
Below.
Below the stomach. Okay. So if inside the stomach, it will be endoscopy.
Yeah.
Yes. There's an
Endoscopy. Okay. But here it needs laparoscopy or laparoscopy. Excellent. Excellent. Okay. So I think this question is clear.
Okay, if it was one magnet, not a lot or not one, more than one, will observe only or also will prepare for laparotomy? If it is one magnet.
High magnet power. If it is high magnet power, we have to go for laparotomy. If it is small, we can observe.
The magnet and
battery
the
for
battery, it's
laboratory.
dangerous. Magnet and the battery dangerous.
Yes. Okay, and even if it's one magnet, okay, we will do
Yes.
laparotomy.
At least he will not discharge. You will consult surgery. You will not discharge.
Yes.
Excuse me, guys. Please.
But it has an algorithm according to patient is symptomatic or not, and it's multiple or single.
Of course.
Regarding this, Dr. Hani, regarding this scenario, I think this last exam, these 2 X-rays after pass magnet down in the bowel, but I think there is 2 options for answer. Refer to pediatric surgeon or laparotomy. At that time, which answer I will choose?
It's according to stability of the patient, I think.
As you see here, you mean refer to pediatric or prepare for laparotomy operation?
No, I think he mentioned pediatric surgery referral and laparotomy. Another one and laparotomy. I already selected laparotomy, but which answer is correct?
Yes. So what do you think?
I think it depends on the presentation of the patient. If the patient is critically ill, you are going directly to laparotomy. If he's stable, you can send him to pediatric surgeon.
I think according to the formulation of the question itself,
you have to stabilize the patient. You have to stabilize the patient. Okay. So if the patient is stable, needs a laparotomy, and if the patient is unstable, you have to stabilize and do laparotomy, right? It's not a big issue.
Who will
Stability.
do laparotomy? Pediatric surgery or ED?
Yes. If they give you, two options, guys, if they give you 2 options, refer to pediatric surgeon.
Yes.
Number 2, prepare for laparotomy. I will choose laparotomy. Why? If you will say refer to pediatric surgeon, it means maybe it's not for laparotomy. Clear?
Yeah.
But according our reality in the ER, what we can do in the any patient stable, unstable, or stable for surgery, so adult or pediatrics, we stabilize the patient, we do everything. Then the surgeon, he will take the patient to OR.
Excellent. Now the examiner is not talking about stability because he did not mention IV fluid, he did not mention blood transfusion, he did not mention analgesia. He's not talking about that. He's talking about decision making now, right?
If you allow me, Dr. Hani, I think the formulation of the question also can make difference. Let us say if he is asking what is the definitive management, or he will ask what is your next step of management.
Excellent. Excellent also. this one can be. So if they ask you what is the definitive management, it's a laparotomy or laparoscopy, okay? But again, if they said what is the next, what is the appropriate management? So if they give you option for refer to pediatric surgeon and prepare for a laparotomy operation, I will choose laparotomy, because if you will refer to pediatric surgeon, here it means for maybe admission, okay? If they give you option laparotomy, it's a laparotomy, okay, guys?
Yes.
So be sure of that. But again,
just comment, doctor. If they give two X-rays, the first one is the substance is there, and the other one is the magnet is already moved down without any intervention.
Yeah, I remember. I'm sorry to interrupt, brother. I just remember the scenario last exam I gave. So the two X-ray was given. One was in the above the stomach. It was like just on the esophagus, and after 2 hours, they came back, and after 2 hour X-ray was around the like in the small intestine. So what is your next management to do? Like observation also was on the.
It is going. It's going to choose the observation or what to do.
Because in 2 hours it moved so much from stomach to it directly came to small intestine.
Yes. Anyways, this patient will be presented with abdominal pain, guys. And also, whatever he came in the first presentation or second presentation, it will be laparotomy and laparoscopy. Okay?
No.
Because it's a different than coin. If coin, no problem. If coin and below the stomach, it's safe. Okay? But battery or magnet, it's not safe because it can cause obstruction, can cause necrosis, ischemia, perforation, bleeding, and so on, and sepsis also. Okay, so this question we can skip or not yet?
Yes, please.
Okay. Unconscious GCS6, repeated attack of seizures, 2 times more than 30 minutes. What is the initial step on management? So he said here, GCS6. What do you think, guys?
Intubation. He's giving you a cut right away to intubation.
Intubate
Okay.
first.
Okay. So,
or less.
do you agree with intubation?
Yes, yes, boss. We can move on.
We can move. Okay. So, please be familiar with the algorithm, status epilepticus algorithm. Okay?
Yes.
Yes.
3 days, baby, brought to ER with struggling of feed and distress. On examination, there is murmur on auscultation. What is the diagnosis?
Congenital heart disease.
Yes, it's a congenital heart disease. Okay. So 3 days, 3 days or 4 days, think about congenital, whatever, heart or lung or whatever. It's not a big issue. But here, he give you murmur. So it's a heart, right? We are talking about heart now. But murmur here, it's a patent ductus or ASD?
Or ASD.
Why?
Patent ductus.
Both have murmur. ASD has pansystolic murmur, and BDA also has pansystolic.
Both of them have it, but which one is more
typical scenario is struggling with feed. So
Patient is struggling with feeding. That's why. That's why it's most probably PDA.
Yeah.
Why?
3 days.
Because struggling of feeding. And here's distress. In ASD, mostly child is not distressed. So this is PDA most probably.
The fusion of the PTA, it will take
and there's the age also, guys. The age also. 3 days, it's going with PDA.
Closure of the ductus.
I was actually about to say that according to the age, it's PDA.
Yes, for the age, it's PDA. And also, as Dr. Imran said, struggling of feed and distress, it's going with BDA as well. Okay. And the third point, it's a very common option or answer in intermediate or final exam. Okay. So, patent ductus arteriosus, it's a common answer. Okay, guys? Always
Dr. Hani,
think.
I think it's VASD, PDA, then ASD. Am I right? For the commonality.
No, I'm talking about common in the exam.
Yes.
Common answer in the exam.
Okay.
So ASD will not come with distress.
It may come, but it will take time. Maybe 3 months. 2
Yes.
months.
I think after 2 months, at least 2 months. Yes.
If you find 3 days, if you find struggling, if you find distress, so think about BDA. Okay.
Okay.
Okay. So here, unlikely to ask you about details, but be familiar with endomycin also. Okay. How to differentiate between BDA or ASD? So BDA present in infancy and ASD common in childhood. Okay. Here the murmur or exercise intolerance, it will be there. Here heart failure can be in the scenario. Remember that. That's why this scenario, it's not formulated completely, right? So you will find symptoms or signs of heart failure. Okay. Here they can ask you, is it left to right or right to left? It will be left to right, both of them. Okay. So severity of difficulties, it will be in BDA, as Dr. Imran said. Okay. #21 scenario about house fire. So if you find house fire, what does it mean?
Cyanide.
Cyanide.
Carbon
Okay.
monoxide.
Cyanide. I don't care about the parameter, because maybe the parameter he put it's not correct, right?
Yeah.
We are not sure if lactate like that or not. We are not sure if BaO2 is like that or not. But anyway, if you find house fire in the exam, cyanide until proven otherwise, guys. Clear? If you find heater, what does it mean?
CO.
CO. If you find, for example, engineer and the generator and maybe CO poison. Okay. But lactate.
House fire can cause both, right? Cyanide and CO poisoning.
Yes, but the priority, if they ask you which of the following diagnosis or which of the following poisoning, CO or cyanide, which one you will choose?
Cyanide.
If they give you cyanide, option cyanide. If they give option CO, option methemoglobinemia, and option cyanide and CO, which one you will choose?
Cyanide and CO.
Clear?
Yes.
Okay.
Excuse me,
So
Dr. Hani.
yeah.
Yeah, the one that always come in, I think, in the exam, the one garage you want to suicide is opening the car.
Yes.
Yeah, I think he's giving lactate too much high, but they always CO boiling.
Okay. So
One in the car and in the car he want to suicide, something like that scenario.
In the garage, you mean?
CO.
Yeah.
In the garage. Okay. So anyway, if you find a garage, check there is house fire. There is fire or not? Okay. No fire, no cyanide. To be sure. Okay.
Yes.
They are very clear in the exam. So anyway, regarding lactate, guys, regarding lactate elevation, because some people, if they see lactate high, they will think about cyanide. It's wrong. Okay. If lactate high, it can be because of hypoxia. and it can be because of non-hypoxia. How? So, in any ABG, if you check lactate is high, it means lactic acidosis. So, lactic acidosis, you will check BaO2. If you find BaO2 hypoxic, less than 11, the normal is 11 to 13. So, it's a type A or type B?
Type B.
Type A.
Type A.
Hypoxia. Okay. So carbon monoxide, it's a type A or type B?
Type A.
Type A. Type A.
Type A.
Okay. If you find lactic acidosis or lactate is high and you check BaO2, it's normal. I'm talking about the exam and I'm talking about the practice. So here, cyanide, non-hypoxia, it means BaO2 normal. So it's a type B or type A?
Type
B.
Type B. It means if you find the lactate is high, it means what?
Carbon or methylglobin?
Or
cyanide.
Or methemoglobinemia.
Methemoglobinemia.
Okay. So what is the differentiation? BaO2. Oxygen. If you find BaO2 is low, it means the type
A.
It means
CO or methemoglobinemia.
CO.
Carbon monoxide.
If you find the lactate is high and the BaO2 is normal, it means
Cyanide.
Clear, guys?
Toxic.
Clear?
Yes.
Doctor, one question. Just one last question regarding this question. So, isn't cyanosis a sign of hypoxemia?
Excellent. When the patient gets cyanosis, we set the normal BaO2, I'm talking about ABG, not pulse oximeter. The normal BaO2 is 11 according to the Royal College, 11 up to 13, okay? Or in millimercury, it's 80 up to 100, okay? Less than that, it will be hypoxia, but not cyanosis. If the oxygen saturation go down 8 kPa, it will cause hypoxia and cyanosis. Clear, guys?
Yes.
If less than 85 millimercury, it will go for hypoxia and cyanosis. So hypoxia doesn't mean cyanosis, but cyanosis means hypoxia. Clear, guys?
Clear.
Okay. So again, if the patient has lactate high, it can be cyanide, it can be CO, it can be methemoglobinemia. So check BaO2. If BaO2 is low, so the lactate here is high because of
hypoxia.
Hypoxia. Why? Because of tissue hypoxemia. Tissue hypoxemia, breakdown of the glucose by anaerobic oxygenation. It will cause lactic acidosis because of hypoxia. I think all people know that. Okay? But here, the patient has lactate high, but not because of hypoxia. Other pathophysiology. Okay? Next question. Anyone has question in the previous question?
Yeah, so the answer in the previous question is CO poisoning because the patient has cyanosis.
How is fire? How is fire? How is fire?
Incomplete question still.
How is fire here?
Only house fire, so we're choosing the cyanide.
Yes,
Cyanide.
house fire,
is
cyanide,
normal
until
here.
proven otherwise.
Okay. Okay.
Okay, guys?
Yes.
Okay. And also BO2 normal.
BO2
right?
normal. Right.
Yes.
And lactate is high. Lactate is high, you can think about cyanide, CO, and methemoglobinemia. 3 poisoning can cause cyanosis, right?
Yeah.
Okay.
But cyanide doesn't cause hypotension. There's the issue here.
Here regarding hypotension, it can be for any poisoning. It's not an indication for specific poisoning. Okay.
And PO2 is
It could be
normal
due
in
to heat
CO.
exposure in the fire. It could be due to everything, anything. Yeah.
Yes, yes.
Dr.
Patient is
Hani,
hypotensive. Yes.
And PO2 is normal in CO.
yes, lactate is high and BO2 is normal, so it is cyanide. Can we move on?
Yes.
Yeah, guys, let us move on, please. It is clear, just the cut. It's house fire means cyanide. That's it.
Okay. Another 19 old female with history of asthma present to the emergency. Guys, can you see the whole slide?
Yeah.
Yes.
Yeah.
Okay. So, history of asthma present to the emergency department with increasing shortness of breath and wheeze, as using increasing amount of salbutamol inhaler over the past few days. On examination, RR 35, heart rate 130. So in a way, don't depend on these parameters. Maybe they will change in the exam. Okay. So be familiar with acute severe asthma, near fatal asthma, life-threatening asthma, moderate asthma. Unlikely to ask you about moderate asthma. So think about acute severe, life-threatening, and near fatal. So according to these parameters, BO2 7.5 and BCO2 normal. So what do you think?
Life-threatening.
So we can move on?
Yes, boss.
Okay. Child had leg rash. So this patient, give me from the image 2 differential diagnoses or 4 differential diagnoses. 4.
Henoxolene purpura.
Okay.
Meningitis.
Hemolytic uremic syndrome.
Okay.
Septicemia.
Excellent.
Meningococcal septicemia. Yeah.
Okay. Excellent. Okay. So it can be non-accidental injury also.
It can be. Yeah.
Okay. So you can expect they will ask you any question regarding this image. So if they give you a non-accidental injury, you can choose ITB, you can choose Henselab purpura, you can choose meningococcal septicemia, you can choose. Okay. So here, this patient is sitting or standing or lying down.
Sitting.
So if the patient is sitting, do you think it's a meningococcal septicemia?
Meningococcal septicemia will be.
Can you see he is sitting? Can you see his leg sitting like that? It means the patient is comfortable.
Conscious.
Comfortable. It's not about conscious. Comfortable. Okay.
Yeah, comfortable.
So yes. So leg rash and history, sore throat also 2 weeks ago. It will be like 3 or 4 days ago. What is the investigation to support the diagnosis? So what do you think, guys?
Urine analysis.
Yes.
Okay, so urine analysis for what?
Proteinuria, RBCs.
Protein and hematuria.
Excellent. For proteinuria and hematuria. Okay, because they can ask different way. Don't focus on the question itself. So they can give you the answer. For example, this patient, you request urine analysis to support your diagnosis, and they can give you the question for what urine analysis. So what is the answer?
Proteinuria and hematuria.
Yes. Okay. And also for what else than urine analysis?
CBC.
No, I mean what is important. I'm not talking about all investigation. What is the most important?
Proteinuria.
We already mentioned urine analysis.
Glomerulonephritis.
Urea and electrolytes.
Excellent. U and E. Excellent. U and E. Okay. So if they give U and E, it's very, very important. Why? Why U and E?
Renal impairment.
Renal impairment. What else?
Antisusception.
Okay. So acute kidney injury and electrolyte imbalance. So this patient also can be with abdominal pain. What is the cause of abdominal pain if he came with abdominal pain?
Intussusception.
You know, she's continuing
Excellent.
the
Intussusception.
also.
Excellent. So what will you order for intussusception?
Ultrasound.
Ultrasound and
Ultrasound,
Ultrasound, air enema.
herbarium.
and stool analysis for bleeding. Okay. Okay. For intussusception. Next
Dr.
question.
Hani, Dr.
Yes.
Hani, one moment, please. Next, previous question.
This
why
one?
not? No. هنوشن ولين بربرا.
This one.
Why not full blood count? Because platelet is normal, so it will differentiate it from it. And
you have priorities. You have priorities here. Okay. Full blood count, it will show you white blood cells because leukocytosis. It will show you if meningococcal septicemia or not, right? White blood cells.
Yes.
Number two, platelet, if low or not. Because if platelet low, you will think about ITB, right?
Yes, or malignancy or leukemia or something like that.
You will check about hemoglobin also. So full blood count here, it's very, very important, but urine analysis is the priority. Okay?
Okay.
Yeah. Okay. 33-year-old woman is admitted with sudden onset of shortness of breath whilst shopping in the supermarket. She has no other symptoms but had laparotomy and removal of uterine fibroids 3 weeks ago. She has no other past medical history, non-smoker, observation show respiratory rate 26, and SBO2 94, heart rate 95, examination, chest is clear, heart sound is normal, no swelling or tenderness in lower leg. What is the correct Wills score? So Wills score, you have to be familiar regarding Wills score in DVT and in pulmonary embolism as well. Okay, so here we will not waste the time in this one because maybe it will be different in the exam, right?
Yeah, just good.
Yes, so be familiar with the criteria in pulmonary embolism and with the criteria in DVT. So what is the borderline for DVT and the borderline for pulmonary embolism, guys?
4.
4.
4. BE.
4 in BE.
For DVT.
Yes. It can be a question. So be familiar with the features, risk factors, and be familiar with the cutoff. They can ask you about the cutoff. Okay. And be familiar with the management in pulmonary embolism. So, if they give you,
guys, please mute.
if they give you probability of pulmonary embolism above treatment threshold, so if submissive without RV strain, it will be mentioned in the scenario. So this one heparin anticoagulation. All you can give heparin anticoagulation for all. It's a mandatory. If submissive with right ventricular strain, it means abnormal echo or biomarkers. If systolic blood pressure less than 90 for more than 15 minutes. So all of them you will give heparin. But regarding if they mention submissive with right ventricular strain, they can tell you patient already given heparin. What is the next step? Okay, so be familiar with this algorithm. It's from Arkham Learning. So assess for evidence of increase of severity, suggest potential for benefit of fibrinolysis. So this patient, you will check he needs fibrinolysis or not. Okay, so check if there is evidence of shock or respiratory failure in the scenario. Okay. Okay. Respiratory distress or altered mental status or appearance of suffering, evidence of moderate to severe right V strain, right ventricular strain. So anyway, you will go for alteplase. Okay, so alteplase first or heparin first, guys?
Heparin first.
Heparin first.
So whatever the condition, which one is the first?
Heparin.
Heparin. But if they said the patient has submissive with right ventricular strain and given heparin, what is the next action?
Multiplex.
Clear?
Yes.
Okay. So anyway, you can go for a BE or CAM learning. It will be easy for you to get. Okay. Next question. 43-year-old present with 1 day history of fresh hematemesis. So what is our topic here?
Hematemesis, upper GI bleeding.
Okay. He has had 3 to 4 vomits, each consisting of mugful of fresh blood. Alcohol dependent. So alcohol here, is it variceal or non-variceal or because of antiplatelet anticoagulant?
Variceal.
Okay. So did he mention here anticoagulant or antiplatelet?
No.
No. So maybe variceal or non-variceal. If he mentioned alcohol, it means variceal until proven otherwise.
Yeah.
If he mentioned, if he did not mention alcohol, if he did not mention anything else, and he said the patient has a severe headache for 3 weeks, what does it mean?
Painkiller, so non-steroidal.
Non-variceal. Means a non-variceal, right?
Yeah.
Okay. So anyway, INR 1.2. What does it mean 1.2?
Normal.
It means it's not anticoagulant or not antiplatelet, right?
Yes.
Okay. Lactate 4.3, glucose 5. So here, which of the following initial intravenous fluid? He's asking about intravenous fluid. I think it's the options here, it's not correct. But anyway, what is the answer, guys? What do you say?
Saline. We'll give saline because patient hypotensive.
He shocked, so 500 to 100 to 1000 Hartmann.
Okay,
Saline.
so
Normal saline.
yes, here according to the guidelines, you can give 500 ml bolus of Hartmann solution or 0.9 sodium chloride. Which one is first?
Hartmann.
Hartmann. So both of them can be? Yes. So I don't think they will give you both options together, right?
Yes.
So maybe it's wrong. If they give you both options together, which one you will choose?
Hartmann.
Hartmann. Okay.
Hartmann.
Yes. So anyway, maybe they will give you one option for Hartmann and saline together. Maybe.
I think so. If lactate is high, that's why normal saline is correct. Hartmann have more lactate, that's why.
Yes. So you have to check. You have to check the scenario in the exam. Don't depend on this scenario. Okay. So in any question, we are discussing all questions. Don't depend on the same scenario. Don't depend on the same parameters. Okay. So here, if they give you INR, for example, 6, what does it mean?
Bleeding.
Is warfarin or
warfarin and
Yes,
coagulation.
maybe
Reversal.
the patient is the patient is using warfarin, okay, and not mentioned in the scenario. But anyway, what I mean, always expect different options, expect different parameters, expect different points in the scenario. So if you mention here variceal, it doesn't mean it will come in the scenario in the exam variceal. Okay, be ready for any scenario.
Okay.
Okay, 87-year-old woman from residential home with 2 days history of diarrhea. She has had 10 episodes of watery diarrhea, but no vomiting. She complained of colic lower abdominal pain. She had 5-day course of antibiotic. If you see antibiotic here, what does it mean?
I think
Clostridium difficile.
So
Associated diarrhea.
this antibiotic associated diarrhea, right?
Yes.
Yeah.
So you think about
Clostridium difficile.
Clostridium difficile. Excellent. Always they will give you like that. They can change chest infections. They can say UTI 2 weeks. So anyway, they will give you antibiotic for disease after that diarrhea. So think about Clostridium difficile. Okay, the new guidelines now, which is the first line?
Vancomycin.
Vancomycin.
Vancomycin. Before it was
Metronidazole.
Yes. So remember that this guidelines antibiotic for adults aged 18 years and over. This regarding Clostridium difficile. First line antibiotic for first episode of mild, moderate, or severe. So it's not about severity. Mild, moderate, or severe. Mild, moderate, or severe, it will be vancomycin. Okay, this scenario is talking about insulin dependent. What does it mean, insulin dependent, guys?
Type 1. Type 1.
Type 1, excellent. What does it mean, 22?
Young age.
Decay.
Type 1.
It's
Okay,
also
so-
with type 1 diabetes.
Excellent. So if you find type 1, young age, and insulin, it means we are talking about decay. It means we are talking about
Anion gap. Hyperglycemia.
excellent.
Higher.
So I want you to be very fast in the exam, to be intelligent. If they will give you insulin dependent, it means he will ask you about anion gap. If they will give you non-insulin dependent or type 2 or old age, they will ask you about
HS.
osmolality. Excellent.
Osmolarity.
Excellent. Okay. So this is how to think when you are studying and how to think in the exam. Okay. So here, be familiar with the difference between HHS and DKA regarding pH, regarding bicarbonate, okay, regarding glucose. So glucose here, how much?
38.
Is it correct?
Maybe more. It is very high.
Maybe less.
No, less. DKA will be less.
less than.
In DK, less than.
More than
less than
13
This is not
HHS.
correct.
So do you think is this one correct?
No.
This is not correct, sir.
Okay. Yeah. So in young age, type 1, you can think about DKA, and also anion gap, think about DKA, right?
Mm.
So glucose in DKA, how much? From
More than
Less
11.
than 30.
11 less than 30.
Mm.
More than 11 less than 30. Why I say less than 30? Because if more than 30, it will be
HHS.
HHS. Excellent. So anyway, you can calculate in the exam. So if they give you potassium, you can calculate with potassium. If they did not give you potassium, no need to calculate potassium. So sodium plus potassium minus chloride and bicarbonate. Okay. 69. Old man present with 2-day history of vomiting and lethargy. Type 2 diabetes. What does it mean, type 2 diabetes?
HHS.
And what does it mean, 69?
Type 2.
HHS also. Okay.
Yes.
Okay. So he said here has known hypertension, respiratory rate 22, oxygen saturation 95, heart rate 104, and the blood pressure normal, mild fever. And he mentioned here blood glucose 2 times, right?
Mm-hmm.
I don't know which one he mean, but anyway, this one, how much the glucose you expect?
40. Maybe 40 it is.
More than 30.
30.
More than 30.
More than 30.
Excellent.
I know,
More than
but
30.
in the
Okay.
question, maybe it is 40.
Okay. So he said here also potassium 7.3. Is it severe or not?
Severe.
Severe. Urea. High or not?
High.
Okay. So we are expecting glucose more than 30, right?
Yes.
Okay. So you will treat HHS or you will treat potassium?
Potassium. To stabilize the heart.
What do you think, guys?
I have to treat the hyperkalemia. I have to treat hyperkalemia.
Treat the cause first.
Repeat the blood sample.
Maybe
If the patient,
hyperglycemia is because of the infection or any underlying cause. So we treat the underlying cause first.
okay. If the patient,
hyperkalemia, severe hyperkalemia, this is life-threatening.
okay. If you find the patient with Addisonian crisis, okay, Addisonian crisis, and he has, I'm not talking about this scenario, I'm talking another scenario. Patient has Addisonian crisis. He has potassium 7.3 and he has calcium 4. Okay, and he has glucose is 2 millimole, and he is hypotensive. What is the first line treatment?
Hydrocortisone.
Or you will give calcium?
No, hydrocortisone.
No, sir, hydrocortisone.
Why not protect the heart?
Potassium already high.
No, the cause is different here.
So if you
It will
will
be
correct
corrected
the
by the-
underlying cause, if you will correct the underlying cause, everything will be normal, right?
Yeah.
Yes.
Okay. So there is difference between scenario with isolated hyperkalemia, only severe hyperkalemia, and no other diagnosis. Okay. And scenario for Addisonian crisis or scenario for HHS or scenario for DKA. Sometimes the DKA was hyperkalemia, right?
Yes.
Yeah.
Okay. So anyway, don't depend on this question. Just check what is the diagnosis. If you can
Actually-
treat that, yeah.
Actually, the management here will treat both at the same time.
Yes. If you will give this patient, if HHS, what is the first line for HHS?
Hydration.
Rehydration.
Hydration.
Hydration, yeah.
Fluids.
So in HHS, you will give fluid and then low molecular weight heparin, right?
Yeah.
Okay. What else?
Low molecular weight.
Insulin.
Insulin.
Okay. So you will start first. You will start first the fluid, and after that insulin, right?
Yes.
Yeah.
Okay. What if the patient has DKA?
Normal saline.
First fluid.
First one
Fluid.
Then insulin.
It will be
Fluid, then
fluid and the insulin. Okay.
And insulin, yeah.
Fluid, potassium, then insulin.
Yes. So anyway, if you find the scenario with severe hyperkalemia and no other diagnosis, so you can start with
calcium chloride.
calcium chloride. Yes. Okay.
Dr. Hani, if it is there is no ECG changes given here.
If there is no ECG changes, it doesn't mean you will not start calcium
No, I
chloride.
mean the other option, if they have given insulin and glucose, other option given, then
Yes, here if you find potassium more than 6.5, even ECG is normal, you can start 10 ml, 10% calcium chloride,
okay.
10 minutes. Okay, so any one of them be indication, whatever potassium is high or ECG changes. Okay, yeah. So this is the ECG. They can give you ECG and ask you the diagnosis also. They can ask you about the finding. What is the finding here?
All T wave pulmonary QRS complex.
Yes.
QRS, BQS.
Yes. Okay. Ambulance with 2-hour history of weakness, reduced sensation, her right face, arm, leg, expressive dysphagia, no loss of consciousness, syncope, visual disturbance, or any seizure activity. So he's talking about what?
Middle cerebral.
Stroke, TIA.
Stroke, TIA.
Stroke and
differentiation between stroke and syncope.
Okay, so if the patient has neurological or ocular symptoms, it's a stroke or TIA. Okay? Any neurological in the exam or in practice, any neurological or ocular symptoms, it's a stroke or TIA until proven otherwise. Okay?
Stroke.
If less than 24 hours, it can be TIA, it can be stroke. But if more than 24 hours, it's stroke for sure. Okay?
Yes.
Okay. So anyway, yes.
About last question about hyperkalemia.
Yes.
Guideline in success and PREP say if there is severe hyperkalemia without ECG changes, no need to start with calcium gluconate.
According to the guidelines, you can start to even without ECG change. Anyway, you can send in the group.
Okay.
In the common group. Okay.
Okay. Thanks.
Yes, welcome. Okay. And also, if anyone has any guidelines related to hyperkalemia, you can send in the. Okay. So here he asked about Rosier score. So unlikely in the exam to ask about Rosier score. I don't know if this is true scenario or not, but anyway, be familiar with Rosier score, and according to the scenario, you can calculate. So loss of consciousness, it will be -1. Seizure, it will be -1. And any asymmetry, it will be 1, 1, 1. And regarding speech, 1, and the visual field, 1. So no need to waste the time in this question. 39, female, following explosion. So explosion here, is it a closed space or open space?
Closed.
Closed. Okay.
Closed space.
Okay. So on examination, hoarseness of voice. What does it mean, hoarseness of voice?
Airway injury.
Inhalational injury.
Compromise.
Inhalational injury. Okay. Okay. So here he will ask you about intubation, right?
Intubation, yes.
Once he will say fire, once he will say hoarseness of voice, it means he will ask you about airway. Okay. So GCS is 12. So here he asked about no guarding regarding the abdomen. What is the immediate priority? What do you think,
Anesthesia.
guys?
Anesthesia review.
Okay, so we can move.
Anesthesia.
Yes. Please.
Okay. Yes. Here previously, 3-week-old boy, 5-day history of diarrhea vomiting. What does it mean, diarrhea vomiting?
Gastroenteritis.
Gastroenteritis. Okay.
Yeah.
During this time, yes. During this time, given only water on bad advice, last vomited over 24 hours. So he can tolerate oral, right? Because the last one, 24 hours.
Yes.
On triage assessment, he appears alert. Alert, it means no need for IV, no need for admission, right?
Yes.
Yes.
Okay. So anyway, the patient after that, he has blood sugar 2.1. What does it mean? Hypoglycemia. So gastroenteritis with hypoglycemia. So what is the most appropriate management? This patient need oral or IV?
Oral.
Or he's conscious. Able to swallow.
So which one?
5 grams stress orally. 5 grams orally.
Recheck after 50 minutes.
So what about this answer? Is it correct?
Yes.
Yeah.
Yeah. Okay. So here, as we said, okay, 22-year-old man present with sudden onset pleuritic chest pain. What does it mean, sudden onset pleuritic chest pain?
Spontaneous pneumothorax.
Pneumothorax.
VP or pneumothorax?
Primary.
Spontaneous pneumothorax until proven otherwise. There is no trauma, right?
No trauma.
Not breathless. What does it mean, not breathless?
Asymptomatic.
Asymptomatic.
Asymptomatic. Do you think chest pain symptomatic?
Chest pain is
No, already spontaneous pneumothorax will come with chest pain.
Yes, all patients with spontaneous pneumothorax, they will present to the hospital because of chest pain. So it's not a feature of symptoms regarding spontaneous pneumothorax, right? So breathless or not, this is the most important. Okay. No significant past medical history. So 22, it's a primary or secondary?
Primary.
And no past medical history, primary or secondary?
Primary.
Non-smoker, primary or secondary?
Primary.
Okay. Stable or unstable?
Stable.
Stable.
What is the most appropriate further management?
Discharge into a bit
And this
respiration.
advice. For 2 hours. And
okay.
Well, it depends on the
Observe in ED for up to 4 hours.
What about 2 centimeter? What about 2 centimeter?
2 centimeter we can observe.
More than 2 centimeters, we have aspiration.
Yeah, observe for 2 to 4 hours.
So he said here in the algorithm, more than or less than 2 centimeter?
More.
So 2 centimeter, it's not more, right?
Yes.
So 2 centimeter here, it's small. Okay. So here, if more than 2 centimeter, you will go for aspiration. But because it's a 2 centimeter only, you will consider the discharge review in OPD in 2 to 4 weeks. Okay?
Yes, discharge.
Yes. So this one, it's not accurate, this answer. You have to choose discharge and follow up with respiratory specialist. Okay. Be familiar with the algorithm. They can change primary to secondary. And here also be familiar with indication. If the patient is bilateral pneumothorax, what is the management? Next step?
Just tube.
Excellent. So if pneumothorax, lateral, left and right, chest drain. If hemodynamically unstable, what is the next step?
Chest drain.
Chest drain. Okay. And you can continue the approach. Okay. Picture of child burn, both for arm child on pain. Always they will give you in the exam burn and the fracture in children. I'm talking about pediatric. Pain, it will be fracture, long bone, or burn. So large burn or a small burn, I'm talking about severity of pain.
Large burn.
Okay, so to say severe pain should be large burn and fracture of long bone. Okay, fracture of any bone, it doesn't mean severe pain. Okay, guys. So they will ask about pharmacological and non-pharmacological, common in the exam, like that. So what is the non-pharmacological, guys, for burn?
Dressing and cold compression.
Dressing and cold compression.
Yes. Okay. Regarding play specialist, it's after dressing. Okay. What about fracture? What is the non-pharmacological management in fracture?
Could be play and attraction. Attraction.
Distraction with toys.
Splinting.
Guys, remember, in burn, it will be dressing and cold compression. In fracture, it will be splinting. Okay? Reduction is splinting. Okay, they said the same scenario. They give first line pain management. It means they are talking about pharmacological management. What do you think?
Nasal.
Nasal. It's a common in pediatric. Nasal diamorphine. How much is the dose?
0.1
milligram per kg.
Yes, 0.1 milligram per kilogram. Excellent. Okay. So 24, generalized fatigue with nausea and deep jaundice, abdominal pain, right upper, vitally stable, parameters, elevated liver enzymes. So what is the diagnosis? What do you think?
Hepatitis.
Hepatitis.
Could be A or B.
Hepatitis B virus.
I will go for hepatitis. Why not cholecystitis?
Because of
there is
deep jaundice?
Liver enzymes.
jaundice, and there is a right upper.
No fever.
There is no fever.
Murphy's sign will be positive.
Okay, so cholecystitis, it will be normal liver function, right?
Yeah.
Yes.
And there will be fever.
Biliary colic, it will be normal liver function.
Liver function, yes.
Okay. Okay. And here, regarding Gilbert syndrome, it will be also elevated only the bilirubin, but not all liver function, right?
Yeah.
In Gilbert syndrome, it will be normal liver function, only elevated bilirubin. Okay. And it will not be very high. It will be elevated, but not very high. 3 times the normal. Okay. So young female came with fever, vomiting, upper right quadrant tenderness, ecteric. What is the diagnosis?
Fever, cholangitis.
Charcot-Red.
Ascending
Acute
cholangitis.
Yes, cholangitis.
Okay. So here, ascending cholangitis, you find the triad. Okay. Fever, constant pain, and also jaundice. And you will find also elevated liver enzymes, right?
Yes.
Yes.
Okay. If you find loss of consciousness and hypotension, what does it mean with the Charcot triad?
Raynaud's Penton score.
Yes.
Acute.
Picture of male skin rash to complain of abdominal pain, jaundice, nausea, dependent on paracetamol. So if paracetamol, it means the paracetamol overdose, right? So here, what is the diagnosis?
Hepatic failure.
Albumin and hepatic
failure.
Of course, it's not HIV, it's not cholecystitis.
Overdose.
Hepatic failure, it can be. Be familiar with paracetamol. They can ask you about any point in paracetamol. Okay. So here regarding more than 10 gram or more than 200 milligram per kilogram, this is paracetamol-induced hepatic injury. Okay. If they mention more than 75, it's a significant ingestion. So they can ask you about that. And also be familiar with N-acetylcysteine. When to give N-acetylcysteine, it's very, very important and common in the exam. So if single ingestion more than 15 hours, if staggered ingestion, timing of overdose uncertain, ingestion more than 4 hours, and the blood result will not be known within 8 hours. They can ask you which of the following is an indication for N-acetylcysteine. Okay.
Yes.
And also when to ask for blood result, it will be after 4 hours. It will be common question in the exam. Okay. Regarding phases, so stage 1, stage 2, stage 3, stage 4. So here the scenario is talking about upper right quadrant pain and rise in liver function. So think about liver injury. Okay, guys. If they mention encephalopathy, hypoglycemia in the scenario, so think about stage 3. Okay. And also they can ask you about King College criteria. Okay. The next scenario, patient with shoulder dislocation. 1 second, guys. Okay. Shoulder dislocation. If they mention shoulder dislocation in the exam, maybe they are talking about orthopedic case. It means anterior or posterior. If they did not mention, maybe they are talking about procedural sedation. It's very, very common in the exam. Propofol. What is the capnography?
Hypoventilation.
Hypoventilation.
Okay. It's not our question now, but once they will mention dislocation, propofol, think about hypoventilation. And what is the management?
Hyperventilation.
Stop propofol.
Ventilate,
and stimulate the patient. Maybe if you will talk to the patient, he will be awake and hypoventilation will be resolved. He will be normal, right?
Yes.
So stimulate the patient first, and if not responding, so back valve muscle. Okay. So here there is another patient need for the room. What about action? It means they are showing you have another patient. So you will discharge this patient now because you have another patient, or what?
No,
No. So what is the answer?
we have to wait for the baseline.
All vital
Then he will come on.
and all
Excellent.
vital signs.
Excellent. So you think the answer is correct?
Yes.
Okay.
Yes, sir.
So be familiar with minimal, moderate, and deep sedation and the general anesthesia. So the effect of all, it can be a question in the exam. And regarding minimum monitoring, it can be a question in the exam. So they can ask you which of the following required for this procedure. So pulse oximetry, you can choose. Blood pressure, you can. Continuous ECG, you can. Wave capnography, you can. And the discharge criteria: return to baseline of consciousness, GCS, vital signs normal, respiratory not compromised, not the vomiting pain should be addressed. And what is the capnography here?
Hypoventilation.
Why hypoventilation in this?
Increase CO2.
Yes, why?
Because propofol decrease the
Because of
propofol, propofol sedation and increase metabolic rate.
Propofol sedation, any patient you will give him propofol, he will get hypoventilation?
No, retention of CO2.
More than
No.
45. Due to retention of CO2.
Yes, guys, but here the meaning of hypoventilation, it means a retention of CO2. It's not the cause, it's a definition, or it's me. I mean,
Maybe prolonged sleeping. Prolonged
Because
sleeping.
of the deep sedation, the patient's
Excellent.
respiratory receptor has decreased, so that's why there's hypoventilation. That was the
Excellent.
retention of CO2.
And maybe the dose of propofol too much. Maybe the dose of propofol too low. Clear, guys?
Yes.
If the dose of propofol too much, he will go in deep sedation. He will go in respiratory depression, right? If the propofol is too low, the dose is too low, the patient will feel pain or not?
Yes.
He will feel.
Not effective. You give him a small dose, okay? And he will feel pain or not? You are doing reduction, and he has dislocation. He will feel the pain or not?
He will feel.
So hyperventilation.
Yes, he will feel.
He will get hypoventilation. Severe pain, it will cause hypoventilation. Okay, guys?
Yes. Hypo or hypo.
So if they ask you in this patient, what is the diagnosis? Hypoventilation of this capnograph. If they ask you what is the cause or what is the reason, so if they give you option over sedation or overdose, you can choose. If they give you heavy sedation, you can choose. If they give you pain,
Severe
you can
pain.
choose. Severe pain, you can choose. If they give you low dose of propofol, yes, you can choose. Clear, guys?
Yes.
Okay. Another scenario: mother brought her son after his. Guys, please, I can go very quickly. I can finish 180 questions very quickly. But believe me, you will focus on questions only. But now I'm giving you hints around the question. Is that okay with you, or I will be very fast?
No. We are okay with that.
We are okay with you, sir.
We appreciate you.
Thank you very much for your.
Just minimize a little bit
knowledge.
arguments and that's it.
Okay, we can continue tomorrow. Okay, we can continue tomorrow. No worries. Okay, so mother brought her son after his loss of consciousness at home, but child active, well, and play normal. So it means something happened to the child, and after that he's okay now. What does it mean?
Stable.
Bro.
Okay.
Yes, brew, I know, but it's because of that, stable. Because of that.
Okay, so shocking, the patient will not be okay until you do management for him, right? Until you will do intervention for him. Congenital heart disease, he will not be okay until you do intervention for him, right?
Yes.
Child abuse, it's not relative, not relevant to this scenario. Okay. Okay. So the only logic, bro. So here, what is the age of this patient?
Less than 1 year.
Less than 1 year. Less than 1. Excellent. Okay. So it will be pro. The most important, you have to be familiar. You should do what, you should not do what, you may, you need not, and so on. This you can find in RCM learning. And also be familiar with low risk, high risk. Okay. So if the patient is low risk, this scenario is low risk or high risk?
Low risk.
Low risk. So what you will do if they ask you, observe 1 to 4 hours, consider blood sugar, ECG, and the pertussis PCR. Remember that, guys, please. Okay, and the shared decision making between you and the family. Consider home with early follow-up, less than 24 hours, if parents confident. So if they have anxiety, so you will admit. Okay, what about high risk? If you feel the patient is high risk in the exam, so needs further assessment and investigation. They can ask you, what is the next step? So the next step here, observe 1 to 4 hours. But high risk, it will be?
Admitted.
Admission. Okay. Okay. Treat any identified illness. Consider blood sugar, ECG, and the pertussis. So both of them consider, right?
Yes.
Blood sugar, ECG, pertussis, PCR. Okay. They can ask you about different questions. What are the differential diagnoses? Okay. So airway obstruction, maybe laryngospasm, maybe reflux, maybe congenital heart disease, maybe arrhythmia, infection, sepsis, hypoglycemia, metabolic disorder, toxins, non-accidental injury. So if you find any one of them, choose. They can ask you about red flags. If you find any one of them, choose. RTA, head trauma, patient intubated. Why is the patient intubated in head trauma?
This is low.
One can
Low
be
GC.
is low. Okay. What else?
Protect the airway.
Unprotected airway.
RV obstruction.
Or facial
Airway
trauma.
obstruction or facial trauma.
Remember that, guys. Any patient with head trauma, remember that raised intracranial pressure. Okay?
Yes.
Any patient head trauma, think about raised always. When you are reassessing the patient, after 5 minutes, after 10 minutes, after 30 minutes, after 3 hours, check for raised intracranial pressure. So patient intubated, whatever the reason, shifted to ICU after stabilization and deteriorated. Why deteriorated?
Increase ICP.
Raised intracranial pressure. Hypertensive and bradycardia. So what is this reflex?
Cushion.
Okay. Initial step. Initial. He did not say what is the most appropriate. He said initial.
Raise the head.
Raise the head. Okay. What else?
Lose the ET tube.
Neutralize the head.
Lose ET tube.
Hyperventilation.
Yes.
Hyperventilation.
Loosen cervical collar and ET tube, tie or tape. Okay. And what is the pharmacological treatment?
Mannitol.
Or hypertonic saline.
Hypertonic saline.
Patient hypertensive.
Mannitol.
Okay. If the patient hypertensive, choose mannitol. If the patient hypo,
guys, please mute yourself.
Hypertonic saline.
Hypertonic saline. Okay. So if they said initial, it means non-pharmacological. Mannitol and hypertonic, it's pharmacological. But if they said initial, you will think about non-pharmacological. Okay, guys?
Yes.
Okay.
But in this scenario, give me also patient has suspicion of cervical trauma. So should I do this step? It's contraindicated.
Yes, contraindicated.
If the patient with cervical collar?
You can do it.
No. Suspect cervical injury together with increased ICP.
Patient with head trauma, any patient with head trauma, Suspect cervical injury.
Yeah, that's why how we'll do raise the head for 30 degrees.
The head of the bed, not the head of the patient. Okay. Raise the head of the bed. Okay. It's called reverse Trendelenburg position. Okay, guys. It will be obvious in the exam. He will not say raise the head. He will say raise the head of the bed. Even if he said raise the head, it means raise the head of the bed. Okay.
Yes.
Okay.
Refusal ICD, yes.
Okay. TIA patient, after what time? So he's talking about DVLA. It's a common question in the exam. What is the most common in the exam? TIA and
Seizure.
Seizures.
epilepsy or seizure. Excellent. Okay. So here TIA and he's asking about car driving. So how much?
1 month.
1 month.
1 month. Okay, excellent. So be familiar with stroke and the TIA. Stroke and TIA same. So 1 month and also 1 year. Okay. And regarding TIA, 1 month. Okay. Multiple TIA, it will be how much? 3 months. Okay. Be familiar with that, please. And seizures also. So multiple seizures in group A, 12 months, in group 2, 10 years. And the first, it will be 12 months in group A and 5 years in group 2 or group B. Dependence, not common. Loss of consciousness, not common. Okay. Patient came with epistaxis, cautery done. What is the most common complication? What do you think, guys?
Perforation. Hematoma.
Okay. So they can ask you about the steps of management. So number 1 is if the patient came with epistaxis. Number 1 is
Pinching the cartilaginous part of the nose.
number 1 is
Compression.
Holding.
Pressure.
number 1 is
Just the patient ABC.
IV access. IV access. Number 1 is IV access. Number 2, pressure on the fleshy part of the nose. Number 3 is
Cautery.
Cautery for the anterior. Yes.
okay. You check if the patient has unilateral bleeding, you can do cautery. Okay. If the patient has bilateral bleeding, don't do cautery. So if they give you scenario with bilateral bleeding, both nostril, don't choose cautery. Okay. If the cautery, yes. If it can be posterior also. Excellent.
Yes.
Okay. If they mention in the scenario you cannot see the bleeding point, it's posterior. If they mention clearly like that, bilateral bleeding, you cannot see the bleeding point, it's posterior. Okay. So anyway, if the patient contraindicated for cautery or not effective cautery, so what is the next action?
Backing. Nasal
Backing. Excellent. Okay. Excellent. Very excellent. Okay, guys. Guys, all people, you have this record?
Yes,
sir. Yes, sir.
It's okay with me. I have no echo.
Not with me.
No.
Okay. I don't know who is the one makes this record, but anyway, it's with all people. Okay. So 68-year-old man in major 3-hour history of central chest pain. So what is our topic here?
Chest pain, yes.
Chest pain. We are talking about cardiology. Unwell, appears pale and clammy. Repeat ECG is shown, this one. What is the diagnosis?
Anteroseptal.
Anteroseptal MI. Okay. So it's a STEMI.
Yes.
Yeah.
Okay. So what do you think is the action? Repeat or
Aspirin 300.
Aspirin.
Okay. So do you think the answer is correct?
Yes.
Okay, the initial action is aspirin for sure. Okay. And here also
But
He
one
said-
thing, Dr. Hani, sorry.
Yes.
He's saying the patient unstable, clammy, and appear pale. So it's me in
Yes.
shock. So
Yes.
for me, I'm choosing transfer to the resuscitation.
No, if you check the NICE guideline, the number one thing is aspirin. before
Okay,
you do
patient.
anything.
Okay, I'm right with you. But
Check
the patient
applies to
unstable, how
guidelines.
you will give aspirin patient unstable? How he can
Excellent.
swallow? How he can
Yes,
swallow?
excellent. If the patient is unconscious, the priority to stabilize the patient first.
But the
If
reason
the
the
patient-
patient is unconscious, he appears unwell, doesn't mean he cannot swallow.
Okay, what he's saying,
We
if
shouldn't-
you
It's
unwell,
It's not about the
shouldn't
swallow,
assume.
guys. It's not about the swallow. It's a patient here unwell
unwell,
and pale and clammy.
yeah.
But
He is in
it doesn't mean
major.
they cannot swallow.
Why he said in major?
It's resuscitation room.
You have to move to
Resuscitation room.
any patient in practice. I'm not talking about the exam only. Any patient came to you in major or in minor or even in the door of the hospital and is unwell. First one is
Resus.
resus.
Maybe
Okay.
patient have some arrhythmia according to the STEMI, with the cause of it, because of that patient is clammy. So you'll give aspirin or you will treat the arrhythmia.
I will give aspirin.
Will
That's what
stabilize
my
the
guideline
patient.
says.
Okay, no way, bro. How?
Okay,
If it's arrhythmia,
so
you'll give aspirin.
No. In this scenario, he said emergency department 2 times. Here is not resuscitation. Even in the option, he say emergency room. The patient is already in.
Yeah,
no, the patient in major,
It's
not
in
in
major.
resuscitation room.
It's in the
In
triage
major.
still. So it's a triage
In
still.
major. You
Yes,
have
this
minor
is-
area, you have major area, you have resuscitation area.
Yes,
Okay,
this
guys?
is my
Right,
point,
so-
Dr. Hani. This is my
Yes.
point, Dr. Hani. This is my point. He is
Yes,
in
yes.
ED, no, and in the option, no resuscitation. Same.
If there is no resuscitation, guys, this single best answer. It means
Yes.
they will give you options. According to the option, you will choose the best answer. Okay? So if they will give you repeat ECG, aspirin, and the STEMI alert, which one is first? Aspirin.
Aspirin.
But if they give you another option, it will change your mind. Okay?
Yes.
You are playing with the options. Okay? Okay. So if they mention major for a reason, right?
Yeah.
Means it triage. It is
And
triage.
also the question
Yes.
is incomplete, Dr. Hani. No vital.
Yes, of course, of course. You can
Yes,
expect
not
that the
incomplete.
question is not complete, maybe not formulated well. Also, in the real exam, it will be clear. Okay, but I prefer discussion because everyone has different minds. Okay, we are sharing.
But Dr. Hani, according to what we have in the scenario, you will give
Yeah.
aspirin or transfer to emergency.
Aspirin, I think, Dr. Hani.
No.
If the patient is stable, you can give aspirin, and after that transfer, no worries. But if the patient is unstable,
According what we have in that scenario.
in this scenario, in
Well,
these
explain,
options, transfer to
Yeah.
emergency room and
That's
IV
okay.
access.
Okay, thank you.
If unwell or an appear pale and calmly, that is mean he's unstable.
Yes.
Unstable.
What does
Yeah,
it mean
sure,
unwell? Why he
Yes.
said unwell?
All the patient with chest pain, they
He's
are
in
they
shock.
are not well.
Because he has
Yes,
MI.
Well,
Pain.
but he's not shocked. He did not lose his consciousness.
He has MI.
He can
He has
take aspirin, shoot. He can take it buccally. He can take it sublingually.
So
You
he
can
can
give him the aspirin
Yes.
while you are transferring him to the definitive area of management. So
Okay,
if
guys.
giving
Anyway,
aspirin
in
is
the
not
exam, it will be very obvious. They will give you parameters, blood
Yes.
pressure, and. Okay, for sure. Don't worry. The Royal College is very direct and very clear. Okay, if they want to give you hypotension, they will give you 70/30, for example. If they want to give you hypertension,
Yes.
200/110.
Like that, maybe. But like this statement, I can say that he is unstable because pain may make him pale and calm.
Anyway, don't think deep, guys. It will be obvious in the exam. Okay.
Actually, if I receive such patient, I will give him aspirin first. Then I will transfer to PCR.
If you don't think about this scenario exactly. if in the exam, if you feel the scenario is unstable, refer to resuscitation room, okay? If you feel the patient is stable, you can start by aspirin and clopidogrel, okay?
Okay.
Clear. Thank you. What is the diagnosis here?
Sinusitis.
Of course, we cannot diagnose with the image only. They will give you a complete scenario. The patient has trauma or bite or. After that, he has this image, so it will be tenosynovitis. But here, as usual, did they started management?
Yes.
Yes.
Oral
received
or
antibiotic.
IV?
Oral.
Most likely it
Received
will be oral.
antibiotics. Yes.
Yes, maybe most likely will be oral. That's why here they put in the option IV. Okay. Okay. So the patient received antibiotic, most likely oral, but no improvement. What is the next step? You will give antibiotic IV or aspiration, or you will refer to surgery.
Refer to surgery.
Surgery.
Okay. So the first, if they ask you the initial management, if they did not give antibiotic, the initial management will be
IV antibiotic.
IV antibiotic.
antibiotic and analgesia.
Yes.
Okay. After that, aspiration, drainage, and surgery.
But aspiration
this-
and drainage will be done by the plastic. It is not from the ER.
Yeah. Yes.
Yes.
Sure.
Initial
Sure.
management, it will be antibiotic and analgesia. But here already the patient on antibiotic, so don't waste his time. You can refer to surgery. Okay. Child trauma, suspected hemothorax. What is the initial bedside investigation, guys? What do you think?
E-fast.
According to stability.
Yeah,
According to what according to
Patient
options,
is
E-fast is the
unstable,
safest one.
unstable EFAS.
And the initial
Okay.
bedside.
But they ask bedside, so EFAS.
E-fast, it's a bedside test, and the
children.
X-ray, it's a bedside
It's
test,
also
right?
bedside test. Yes.
Yes.
Portable-
So what do you
portable
think?
X-ray.
Here the
E-fast.
option: E-fast or X-ray?
Well, now it's preferring E-fast
More sensitive.
more than X-ray. Preferring
Okay.
E-fast.
It will give you benefit more in pediatric.
No.
No.
For me, I will go with X-ray. I think because I think I've read a study about the less specificity and sensitivity of the path in the children. So for me, I will go with X-ray.
No, E-fast is very sensitive for hemothorax.
E-fast.
Very, very
EFAS
sensitive.
has
than
low
X-ray.
sensitivity in children less than 10 years.
Okay.
Also, in EFAS, you can see small amount of bleed.
Actually, guys, maybe also X-ray you will find in the scenario. Sometimes it's already in the primary survey in trauma, so you will order for chest X-ray and pelvic X-ray together. Okay, and this is common in OSCE exam. Okay, so maybe already X-ray is there. They will not give you option for E-fast and the X-ray together. But anyway, if E-fast and the X-ray, the initial is
X-ray.
X-ray or E-fast?
X-ray.
X-ray is the initial. So all patient, you are doing X-ray for them. But after X-ray, you can do E-fast. Okay. So if the patient is stable, what is the best one?
CT, the best one is stable.
CT. If the patient is stable. So anyway, the most important, guys, to check the question, they said initial. Initial.
Yeah.
Which one is initial here? X-ray or E-fast?
X-ray.
X-ray.
Yes.
X-ray. Okay.
X-ray.
All patients, you will do E-fast or X-ray first?
X-ray first.
X-ray first.
No.
No,
But it's not a bedside.
Dr. Hani,
It's
they say
X-ray.
bedside.
No.
Bedside.
The bedside is not X-ray.
Yes, EFAS.
Hemothorax.
I can do EFAS, but I cannot do X-ray just by technician.
Dr. Hani,
No.
remember that E-fast is part of trauma ATLS survey. Part of our C is E-fast, and it's done at bedside, not X-ray.
X-ray is portable. Portable X-ray is
Portable X-ray. Portable
Okay,
X-ray.
it have,
Is
but
it
it
bedside
need
test or
technician
not?
also. But it need technician also.
Yes, I cannot do that by myself, but if I can do it.
Yes.
Can I say something? Excuse me, guys. In the ABCDEF, X-ray is involved in the E, I think. But there is a separate.
No, it's EFAST. EFAST is part of the C. In trauma,
Excuse
you must have your
Excuse me, this patient is suspected hemothorax. In X-ray, hemothorax will not come, okay? So the first is we have to go for E-fast, and it's very quick, much more better than X-ray. That's why we have to save the time and save the patient.
Excuse me, guys. Regarding if you reflect this scenario in our reality in ER, we are use eFast because it is fast already, and you catch another in trauma patient, another life-threatening like free fluid collections, and another point the eFast sensitive in to catch hemothorax and pneumothorax more than X-ray. Accordingly,
Yes,
is a
I
part
agree
of
with you.
ATLS.
eFast in reality and theoretically, in my opinion, is the best.
Yes.
EFAS is a
Also,
part of ATLS.
even a small amount of hemothorax can seen by EFAS, not X-ray.
Yes, and this is a most important point.
Yes.
Focus.
Yes.
Okay.
So, Dr. Hani, your opinion?
I agree with you guys. Fast is the most sensitive and also has specificity and sensitivity than X-ray. But again, check the scenario in the exam and be sure that they are mentioning X-ray only or portable X-ray. And regarding which one is better, fast for sure. But initial doesn't mean which one is better. Okay, so here initial it means the first step. Okay, initial. Okay, so anyway, fast of course we all agree regarding that. But check in the exam if this patient is stable or not, and if unstable or not. Okay, and so on. Okay. Anyway, I think all of you guys agree with eFast.
Yes.
Yes, sir. Yes.
Okay.
What about your opinion, Dr. Hani?
Okay. Patient postpartum, 7 days, came to ER with fever and fatigue. What is the diagnosis? Until now, we have no more information, but postpartum, it's very clear. And here, the patient has fever only and fatigue. There is no more information. Okay. Okay. So here, regarding hemolysis or septic shock or uremic shock syndrome or DIC, you have to check septic shock. You have to check symptoms of sepsis and symptoms of infection. So whatever cool, pale arms and legs, high or very low temperature, lightheadedness, little or no urine, low blood pressure, palpitation, rapid heart rate, restlessness, agitation. So these are septic shock. If you find symptoms of DIC, like bleeding, whatever the patient has, vaginal bleeding or epistaxis or rectal bleeding or urethral bleeding, so think about DIC. Blood clots also, bruising, drop in blood pressure, shortness of breath, confusion. So think about DIC. So in a way, according to this scenario, do you think you can answer with this information?
No,
it's very difficult.
Yes. So anyway, think about septic shock and DIC.
Yes.
Otherwise, it's unlikely.
It's rare.
Okay. Okay. Next question. You are the leading trauma, so you are the team leader of ATLS, multiple casualties of RTA. You have a patient who has a blunt abdominal trauma and lost cardiac output 45 minutes. What does it mean, lost cardiac output 45 minutes?
low heart rate or bradycardia.
Arrest.
Do you think this patient you will do resuscitative thoracotomy?
Out of the frequency.
Because it's abdominal trauma.
Excellent.
More than
So
15 minutes.
they mentioned that for a reason, right?
Yes.
Okay. Surgical registrar wants to perform resuscitative thoracotomy. While you are against it, your consultant is busy in intubating a child from the same accident, and he is not to be disturbed. It means you cannot call him. What will you do?
I will override the surgical registrar.
Okay. Who else?
Discuss with your team to stop resuscitation. D. Discuss with your team to stop resuscitation.
Surgical registrar.
No. I think we should discuss with team
Because
to.
already it is known, thoracotomy should be done with
No need discussion because
Time
there is
has
no
already,
indication
so
for
we have to
that.
stop the resuscitation now because 45 minutes already. Patient is already cardiac arrest.
No indication.
Yes.
So we should stop now.
It is a teamwork.
Yeah, we should discuss
So
and stop the resuscitation now.
I will explain the question by different way. If they told you I will intubate this patient, or this patient will send to laparotomy,
No.
what will you do? You will override?
override.
Override.
Dr. Hani, it is you are leading a trauma case, so that I'm a team leader. I'm a team leader, so I can
You are
override.
controlling everyone.
But he cannot control me. I am the leader right now.
Yes.
Yeah.
I'm my senior also.
Controlling everyone. Yes.
But you are the team leader.
But there's a quality of a good leader.
Not the registrar. Not the registrar.
Yeah, but the team leader has the authority to take the decisions. He is the one who is leading the code. I am the one who is leading the code.
Yes, so
but,
Dr. Musa,
but the
Dr.
ATL
Musa,
guidelines are telling us, ATL guidelines are telling us it is better to discuss, not to override. Override is not a good word. And in if we are doing MRCM, so they will take it in another way. So it is better to discuss with your team. That's what I think.
If I may say, the question is considering me as a junior doctor, so I will go
No,
with this.
he's saying you are the team leader.
If I'm team leader, I will
override. I will override the surgical registrar. There's no time to discuss.
This question, guys, it's not for level, special level. This question is talking in general. You are leading a trauma case. It's very clear. Okay. So you are the team leader now. What do you think? But you are not the consultant.
I think people shouldn't
Consultant already busy. Consultant busy.
So I think it's a polite way. I think it's a polite way to.
As a team leader, I will want to stop resuscitation. As a team leader, I'm not going to make the decision on my own.
Yes, I agree.
People if they agree, isn't it? Before stopping resuscitation.
I do agree. Because also, if you are a team leader, in each single moment or each single procedure, you have to discuss it with your team. So I will pull back and go with the discuss it with your team.
Yeah, you just ask. Do they agree? It's part of discussion.
What you will discuss with your team? You will discuss what with your team? If you want to discuss with your team.
Okay.
No, so dear, it's in the ACLS. Guys, sorry, if you let me tell you something. In the ACLS mega code or in the ATLS, even if you are the team leader, they will tell you you have to discuss each procedure with your team. Although the final decision is yours, but you have to discuss it first with your team.
What you will discuss with your team, it is already lost time.
Yes. Why are you wasting time? It's clear, it's straightforward.
Okay.
So also I have multiple cardiology. We can go with option 1, continue resuscitation until your consultant.
No need of consultant. No need of consultant. This clear.
Here also, it's a 45 minutes, guys. 45 minutes.
Clear, Dr. Hani. Your answer is
secure for 45 minutes.
Override.
Actually, we search for that in ARCM learning, ARCM guidelines. It will say clearly override the registrar. So,
yes,
Dr. Hani,
right.
what you can Dr. Hani, what you think? Because we need to move on.
For me, it's controversial. Okay, so it can be discussed with your team because you have decision making here. It's a sharing between you and your team. Even everything you will do discussion with your team. Even the briefing, it will be discussion with your team. But override the surgical registrar should be after discussion of your team. This is my point.
Yes.
So both are correct, but overriding it will be after discussion with your team. Okay, guys?
Yes.
Okay, thank you, Dr. Han.
So we can go to the next question. Patient SVT is stable, but nurse is struggling to measure. He said stable, right?
Yeah.
Struggling to measure, it means it's not unreadable. It doesn't mean unreadable, but he said stable. Okay. So
Maybe the cover is not correct.
Yes, I cannot depend on blood pressure now. Okay, because heart rate over 200. So what do you think, guys?
First, DDC.
Okay, so
patient unstable DC.
Stable patient.
Stable. He said stable.
Yes.
Excuse me.
I will go with Valsalva maneuver because the signs of stability of the heart, either if there is any syncope or low blood pressure, or there is signs of ischemia. So for me, the stable, I will start with Valsalva maneuver.
Yes.
Yes. It will be clear in the exam. For example, maybe blood pressure not reading, but if they mention the patient is alert and the CRT is 2, and he did not mention clammy or pale or anything.
Yes,
so
yes.
You can go for stability, right?
Yeah, right.
Yeah.
Okay.
Because maybe it's equipment failure or something like that.
Know how to
Yeah. Sometimes the blood pressure not reading after 5 minutes, it's normal. Okay.
Dr. Han, excuse me, one question, please.
Yeah, sure.
What in the adversive sign, they said extreme heart rate. So what is the cutoff there here? More than 200, more than 220. So to make it as adverse.
Yes, we discussed that in the start. I will repeat again. If the patient more than 220, I'm talking about pediatric, more than 220, and the patient is infant, so it's SVT. If more than 180 and the patient is a child, so it's SVT.
Cardia. Yes.
Okay.
Regarding the adverse features, which it will indicate instability, they mention that extreme heart rate, يعني very brady, very tiny.
With the syncope, with the hypertension.
If they give me 200, يعني, I will consider it.
No, guys, no. Don't be confused, because all SVT, it's already how to diagnose SVT. How to diagnose? It's more than 220 in infant and more than 180 in a child. Okay, so don't care about the heart rate, because already how to diagnose SVT by heart rate. So it means all SVT you will give this a shock. It's not logic.
No need.
Not logic.
Yes.
Not logic.
If the patient is stable, we can go with Valsalva maneuver.
Yes. Okay. So anyway, the most important here, guys, check the age, because maybe sinus tachycardia, and there may be option here just to observe, right?
Yes.
Be take care. Okay.
Doctor,
ECG is important. ECG.
This is DC shock, not synchronized DC. So this is away from our.
No, this may be because of the formulation of the question. In the scenario, it will be DC synchronized shock.
And if we consider BB low, it is contraindication to give adenosine first.
Yeah, but here again, you have to check other features of shock, CRT, Bale Kilemi, the pulse. They can say, for example, weak pulse or normal pulse. Okay. So check other features of shock. Okay, don't depend on blood pressure only. He said struggling to measure blood pressure. It doesn't mean it's low blood pressure. Okay.
Extreme of heart rate is also an adverse feature.
Okay. So I think the scenario in the exam will be clear, right, guys? We can move on.
Yes.
Yes, boss. Thank you.
Yeah. Paramedic has called you for advice on a baby who is dead in his home. So here you have to check in the scenario, the patient is already dead or not. Okay. In his home, in his cot, what should be done next? What do you think, guys?
Bring to the patient to the ED.
No.
Yeah, for me, I've read a policy today regarding UK government.
I think all people they read about this question.
Yes.
About all people.
Yeah.
Okay.
Yes.
What do you think?
We will bring the baby to ED.
Okay. For me, I will bring the baby to ED. What else? Anyone else?
No,
Stay there until baby will be.
It is A because
How come to bring the baby to ED without any information of police or authority or
No,
anything?
actually,
One thing.
This maybe related to forensic. If you take baby with you, you will destroy the evidence. So better to call police authority. If you
This is not your
because if you take
problem.
baby,
You're a doctor.
you will destroy all the evidence.
Okay, Dr. Imran, what is your answer, please?
But first, I have to confirm the death of the baby.
Yes,
That's why I have
doctor.
to
You are not a policeman to check
If you
all the
allow me,
evidence.
guys, if you allow me, I will send it to you a screenshot. There is a clear guideline from the UK government that any pediatric death outside the hospital at home, you shall bring all babies to the ED, except in some situation you will inform police. So the answer is
you mean that, doctor?
Yes, the meaning that any death of children outside hospital, you will bring them.
Can
to
you see
ED.
the slide? Can you see the slide?
Yes,
exactly,
it's the same.
Dr. Hani.
It's the same. It's the same, Dr. Hani. Thank you.
Okay.
Yes, please send it later to the group.
Who will bring? Because this paramedic tell you, paramedic or there, he tell you.
Okay.
Bring with the ambulance.
Okay. So all infants found collapse. It means still alive or dead. Clear, dead.
Yes.
Okay. Whatever collapse or dead. So it's not about alive or dead. Should be taken to the nearest emergency department with the facilities for pediatric resuscitation. So the most important, you have pediatric resuscitation or not. Okay, guys? So check the scenario if you have pediatric resuscitation or not, including the presence of trained resident pediatrician and anesthetic team. Okay, guys?
Yes.
Okay. So anyway, I will send the guidelines. I know it's like 80 pages or 90 pages, but it's very helpful. When you are reading guidelines, don't waste time, guys. Just read quickly, okay? Okay. So what do you think regarding this question, guys?
Bring
it to ER.
Okay. Okay. Next question. All the female on chemotherapy.
Sorry to interrupt you, Dr. Hani.
Yeah.
In previous question, does this make a difference that the paramedic is calling you, like maybe he has tried the resuscitation or something like that? Will it make a difference in the guideline? Because they haven't mentioned there. They just mentioned that if anyone, all infants found collapsed, they didn't mention if medical personnel has seen the patient or not. Does this make a difference? Like, just to confirm.
Yeah, all infants here should be taken not by you, by paramedic, because you are in the hospital already.
No.
Okay.
Just according to this guideline, it means that we need resuscitation of the patient.
Yes.
So,
yes, they said collapse or dead.
Yeah. In order to resuscitate the child, we need to take the child to the hospital. But if the paramedic is calling, maybe paramedic has tried that resuscitation.
Excuse me, can I say you? Bro,
yes.
The patient, okay, paramedic is with him. But there is two points. One of them, there is a high chance for the pediatric dead patients to return back to the life. You don't know if it's dead or not. Then the job of decision of the patient is dead or not, the job of doctor, not a paramedic. You decide, not the paramedic.
Yes, I got the point of the first comment you mean you can try to resuscitate the patient and then bring it to the hospital. This is your point, right?
Yeah, just to...
Yeah, here, guys, it's clear. All infants found collapsed or dead should be taken to the nearest emergency. Of course, you will do resuscitation when you are bringing the patient, right?
Right.
Do you think you will bring the patient without resuscitation?
No.
No.
Clear, guys?
Yes,
Yeah.
The ambulance, when they are bringing any patient to you, they are bringing without any intervention?
No.
Of course not.
They will start intervention, of course. But here, the most important, bring the patient. Of course, when you are bringing the patient, you have to start IV access or IO access and oxygen and. Okay?
Okay. Thanks.
Welcome. All the female on chemotherapy. When they will say chemotherapy, what does it mean, guys?
Low immunity.
Neutropenic sepsis.
Immunocompromised.
Until proven otherwise. Yes. Last decision, 10 days vitally stable, complaining of dysuria. What is next step? What do you think, guys?
So we should do the six S's for the sepsis.
Yes.
So it's each one, CBC, urea, electrolytes, and those.
Excellent. So 3 in and 3 out.
Yes.
6 sepsis. Okay. I think we're all familiar with 6 sepsis. So anyway, don't depend on this scenario. Just check. But the most important here is
chemotherapy.
Antibiotic.
Here, what is your concern in chemotherapy? And neutropenic sepsis. How to understand it's a neutropenic sepsis?
UNT.
Full blood count?
Yeah, neutrophil.
Count less than 0.5.
Yes.
Pressure more than
Signs of sepsis.
Temperature more than 30.
Here in option 1, full blood count?
No.
Option 2?
No.
3?
No.
5?
No.
So 4. Clear?
Yes.
The most important, your concern. Stable. He said stable for what? Maybe you will discharge. So don't discharge until you exclude
sepsis.
Neutropenic sepsis.
Neutropenic sepsis. Clear?
Yes.
Okay. All the female, again. Breast cancer, immunosuppression.
Yes.
Fatigue, dizziness, febrile. So think about neutropenic sepsis also. Antibiotic. Ask for antibiotic. What is the appropriate management for her condition? Also 3 out and 3 in.
Yes.
6 sepsis.
Same one.
Okay.
Yes, same one. Yes.
Same. Okay.
Yes.
Okay. So oxygen, fluid, IV antibiotic. What is the antibiotic for her? Do you remember?
Yeah. Tazobactam.
Tazocin. Tazobactam 4.5 grams.
Excellent. Okay.
Tazocin, yes.
Okay. Double fang marks. Venomous snake bite picture. They will give you picture. Patient's vitals were okay. So it's for a reason here. Had a rash around the womb and bite have 2 fang marks. No systemic upset. Only showed picture of fang mark. It means the patient is stable, only bite mark.
Yes.
So what do you think? According to the guidelines.
Analgesia.
Why analgesia? Any pain here?
No.
Antivenom. But there is a rush for antivenom.
Anti-tetanus.
There's no antitetanus here.
So
Rush around the wound.
In the guideline, it defines antivenom only for if there is any systemic manifestation.
Not all snakes are venomous.
Not local. So this is local manifestation. So for me, I will go with analgesics only.
Okay. All snakes are not venomous. So
Analgesia
we
for
should
what?
not use.
Analgesia for what? There is no pain in the
Only
scenario.
antihistamines for local
we still have 2 options here, guys, right?
Yes.
Or we'll give antihistamine
Options.
for rush. No need
Maybe.
for antivenom here.
Okay.
No
You have
indication
the
for
type of
antihistamine.
snake.
some types of snakes, they are very dangerous. So we have to start.
Yes, maybe it will come late, so that I will wait till it came.
The indication,
guys,
excuse me.
More than one indication for antivenom.
There
There is
is
instability, and there
Doctor,
is any problem around the snake bite, and another one of there is any bleeding abnormality.
if you don't mind, doctor, if you don't mind, doctor, there is a written guideline according this when to give antivenom. So the guideline was clear. Only if there is any systemic, like bleeding, like raising our two joints, something like this. But they didn't mention anything about antihistamine, and they didn't mention to give antivenom just as a prophylaxis. This is the guideline.
Guys,
it was clear.
Some of you, I don't remember who exactly, he shared the guidelines of antivenom in the group, in the common group. Okay, it's very clear. Okay, but be familiar with the indication when to give. They did not mention which snake. So maybe option here to observe the patient, maybe option to discharge the patient, right?
Or maybe anti-tetanus, because all the
maybe anti-tetanus.
indication,
So
all of them is
you have to
indicated for
expect, excellent. You have to expect the two options and be ready for any of them. But give supportive management if he has symptoms. Okay. So here, if the patient has pain, give analgesic. If the patient has blah blah blah, give him blah blah blah, and so on. Okay, guys, don't think about this question itself. Think about the expected question in the exam. Okay, be ready for that. I will share the guidelines again, guys. You are in a restaurant. You are not a child who is 18 months old present with shocking episode, gasping and unresponsive. So what does it mean, unresponsive?
Collapse.
It means you have to restart what?
Give 5 rescue breaths.
5 rescue breath.
CPR.
No
5
CPR.
rescue breath.
5 rescue breaths.
5 rescue breaths.
Yes, you have to start the CPR, but before CPR,
you have rescue breath.
Because pediatric, right?
Pediatric, yes.
If he said here adult,
Start
CPR. Start CPR.
So you have to check the age.
Yes, BBA, ABC.
Okay. If the age is adult, start CPR. If the age is young, so you will start 5 rescue breaths. Okay. 35 years old lady. Guys, we will finish at 60 questions and we can continue tomorrow. Okay. We still have 60 questions.
Sure.
Okay. 35 years old lady developed sudden onset occipital headache. What does it mean, sudden onset occipital headache?
Yes. Subarachnoid hemorrhage until proved otherwise.
Excellent. Until proven otherwise. Associated with multiple episodes of vomiting. So currently on OCB.
Venous sinus thrombosis mostly.
So OCB here, it's a high risk for bleeding or for thrombosis.
Thrombosis.
Excellent. Okay. So what do you think, guys? Okay. All agree regarding the venous sinus thrombosis?
No. Vertebral artery dissection. He said
Hani,
the local yesterday.
he mentioned that the patient went to salon hair wash in the local salon yesterday.
It's also the risk
And
factor for the venous thrombosis.
Also risk factor for Baller syndrome.
But it is
vertebral artery dissection.
Yes.
You mean the same scenario in the exam before?
Yeah, same scenario because he mentioned that patient did hair wash in salon.
Yeah, because of
also he mentioned
all mechanical impingement of vertebral artery, beauty salon stroke syndrome.
Yes.
Okay. Okay. So anyway, I said many times, don't depend on the information in the scenario. So if you find any modification, you have to modify your answer also, right?
She is on OCP, so there is thrombosis chance because OCP involved in thrombosis. So CVT is
If the patient on OCP, there is high risk for thrombosis for sure. Okay. Yeah. But if you have any modification in the scenario for any other diagnosis, you have to consider that. Okay.
Yes, I'm sure that he mentioned patient went to salon and he did hair wash yesterday. Yes, this I'm sure he mentioned this one.
It's written there. It's also written there in the scenario.
It's
Okay.
here also written.
And the headache started when?
Sudden onset occipital headache.
Sudden, yes.
After the hair wash.
If
After the hair
vertebral
wash, yes.
artery dissection,
Yes.
After
if
the hair wash.
vertebral artery dissection, that is mean a patient will come by sign of stroke or symptom of stroke, صح? Or no?
Yeah.
Yeah, here if this onset after the event, so it's related to that event. Okay.
Can I ask you that about multiple episodes of vomiting? It's related to increase intracranial pressure with subarachnoid hemorrhage?
What?
I think they dropped this question. It's very confusing.
Here it's formulated by someone. Maybe in the exam it will not be like that. But anyway,
No, in the exam,
this is the
it's
same
like
question.
this. I'm sure for
Same
this one.
question.
Yes, different scenario. That OCB, different scenario of that patient go to salon. I am sure about this.
Actually, the
subarachnoid hemorrhage is also related with any sudden activity, stressful activity.
OCP.
Yes.
Maybe he
OCP
wanted to
side
confuse with
adverse effect is OCP's adverse effect is thrombosis, so it's correct. It's more chances to get this venous sinus thrombosis. It is caused thrombosis. It's
But
adverse
regarding the presentation, venous sinus thrombosis will come with the ocular manifestation, and it will not be severe headache, occipital headache, and vomiting, same like subarachnoid, I think.
No, even it's all the presentation for venous sinus thrombosis will be accepted. Sudden onset, ocular, non-ocular. There's no specific. There is a lot correlation with the subarachnoid. You cannot differentiate between them according to the onset of the pain or something like that between
It
subarachnoid
can
and
be
venous
also
sinus thrombosis.
in success mention risky factor اللي هي OCB and recumbency position for long time.
Yeah,
That
you're right.
means salon.
That's why it's
Yes.
C. Yeah,
Yes.
you're right.
It may be in from the beginning the vertebral artery dissection, but complicated by subarachnoid hemorrhage. Sudden OCB may be this mean that there is complication occur, which is subarachnoid hemorrhage as complication for the vertebral artery dissection. It's one of the complication of the vertebral artery dissection is subarachnoid hemorrhage.
But can I say something?
vertebral artery dissection.
Can I say something regarding this issue?
Yeah.
I just read on Oxford the presentation of vertebral artery dissection. Besides headache, which is mentioned here in this scenario, there is other presentations which are not mentioned, such as neck or facial pain, pulsatile tinnitus, and like that, TIA. All of these are mentioned in the presentation. They are not mentioned here. Maybe they are missed due to the guy who is prepared this scenario. I don't know. But there are headache and neck or facial pain, especially around one eye or pulsatile tinnitus. This is in vertebral artery
There is
dissection.
no
Excuse me, guys.
scenario.
Dr. Hani, you can give ideas. You can move.
Hyperextension and long time hyperextension and the OCP is also a risk factor for vertebral artery dissection. Plus female gender plus less than 45-year-old. So she is 35-year-old. She has the history of long extension in the salon for hair wash. So my option, I think, is well for D. And OCP is also the risk factor for this vertebral artery dissection.
But you know, guys, a stroke here, a stroke can be hemorrhagic or ischemic, right?
Yes.
Yeah.
we cannot choose stroke because stroke here can be hemorrhagic or ischemic, right?
This is thrombus, so that's no stroke.
No, I mean option B, stroke.
Yes.
It's not clear if hemorrhagic or ischemic because stroke can be hemorrhagic or can be ischemic, right?
Yeah,
Can
yes.
be bleeding or infarction. So we cannot choose stroke, okay? And also we don't have neurological symptoms here.
Yes.
Okay, the patient doesn't have, for example, weakness or paralysis or sensory loss. Subarachnoid hemorrhage, here one of the options, but OCP can override that. Okay.
Yeah.
Vertebral arteries dissection can be, but I will go for venous sinus thrombosis. So what I need from you guys, be ready for all options. Maybe in the exam, the scenario will be clear. So be ready for features of subarachnoid hemorrhage, features of stroke, features of venous sinus thrombosis, features of vertebral artery dissection. Clear?
Yes, thank you.
Okay.
So clear.
But for me, I will go for venous sinus thrombosis because of OCP. This is my point. Okay. 12 years old boy presented with abdominal pain and vomiting. Blood gases revealed severe metabolic acidosis, high blood glucose. So what is the diagnosis? I think the diagnosis is clear.
DKA. Yeah.
DKA. Okay. So young age, DKA. And here, what is your insulin regime? So what do you think?
It's clear. C.
D.
0.1 unit
C.
per kg per hour. 0.1 unit per hour.
Will start by
Yes, you will
0.05.
start. Then
Yeah.
according to the blood sugar, you will increase or not.
Yes.
So, according to the Royal College guidelines, children with DKA should generally be commenced on 0.1 units per kilogram per hour. So, when to start 0.05 in 3 cases. Children undergoing inter-hospital transfer. It means when you are transferring the patient because limited access of monitoring. I think this one is logic. Children less than 5 years. Remember that. So you have to check
The age.
the age. That's why here the age 12. Maybe in the real exam it was 4. Okay, guys?
Yes, yes.
Be ready. Children with blood glucose less than 15. So you have to check the blood glucose in the scenario. Okay, guys?
Yes.
Yes.
Okay. This, I want you to think like that, guys. It's not about memorize the question or memorize the option. Maybe the option will be 0.1. Maybe it will be 0.05, right? So be ready. Be ready. Okay. Which of the following is the earliest sign? Earliest. Barton syndrome. What do you think?
Pain on passive stretch.
B. Yes, I do agree. Pain on passive stretch.
Okay. CPR rate. So here you have to be familiar with early signs and the late signs.
Yes.
CPR rate.
It's clear.
120.
Yes, we all agree for that.
Okay. Do you need the age?
No.
Yes, I need the age.
No.
Why?
CPR.
No, you don't need age.
Rate.
Neonate.
Ratio.
So rate.
Rate. Yeah.
Rate, not ratio.
Yeah, rate. Yes.
Okay. Scenario of trauma. Asking about posterior border of safety ring. I think this one, it's clear.
It's clear. Yes.
That is middle side, correct?
Okay. About patient driving have decompression sickness. We have 2 types of decompression sickness, which is not included, guys.
Dizziness, headache, all of them is going. Joint pain, weakness of the arm. It's all clear. So it's itching, yes.
Itching.
So we have 2 types of decompression sickness, type 1 and the type 2, which is dangerous.
Type 2.
Type 2. So type 1, it's not life-threatening, and type 2, it's life-threatening. Symptoms are pain, joint pain, skin irritation, Skin irritations. Okay. So skin irritation there or not?
It's there.
You mean
It's called
itching?
Fusus marmorata.
We will discuss more now. So what about type 2? Type 2 is the most serious and can be life-threatening. There's 3 different forms of type 2. Number 1, cerebral decompression sickness. Of course, the decompression sickness, when the patient is diving, after diving, he has symptoms. Why? Because bubbles go in the artery. Okay. So here, cerebral, it can affect the brain. So it's called the cerebral decompression sickness. When bubbles get in the arterial bloodstream and move into the brain, which can cause arterial gas embolism. Number 2, it can affect the lung. So pulmonary decompression sickness, very rare and only occurs when bubbles in the lungs. Number 3, neurological. It means neurological decompression sickness, when nitrogen bubbles affect nervous system and cause problem in the body. So each one can be a question, and also types. They can ask you how many types, okay, and which one is the life-threatening. Here, regarding symptoms and signs, fatigue, itchy is there or not?
Yes.
Pain, joint muscles, dizziness, ringing in ears, numbness, tingling, paralysis, SOB, rash, okay, paralysis, weakness.
Headache is not there.
Yeah, excellent. Difficulty urinating, amnesia, tremor, staggering, bloody, frosis, sputum, collapse, unconsciousness. So what do you think, guys?
So we are go with headache.
Yeah, okay. For me, I will go for headache. Anyone agree with that?
Now we change our mind.
Okay.
For Hani.
Yes, I agree.
Yeah.
Yes.
But how the patient had embolized and going to the brain will not have a headache.
Yeah. I searched about this point before the session. I did not find headache.
Okay.
Yeah.
The successive is mentioned. Headache is mentioned in success. One of the features.
1 second, guys.
There is a headache. I check it and succeed in other books as well.
Yes.
Yeah. Let's say constitutional symptoms like malaise, headache, lethargy, loss of appetite, and apathy.
In success, there is headache. Yeah.
Success is headache.
Yes.
I also
There
check
is
with
a rash. There is a rash, but it didn't mention any itching.
Okay, guys. So you have to search again, and I will search again. Okay.
Yes.
Yeah, sure.
Okay. So the last question for now, and if you are happy to continue tomorrow, we can continue.
But at what time, Dr. Hani?
We will see. I will mention in the group. Okay.
We record it tomorrow because we are traveling tomorrow.
Okay. Scenario about baby 2 years come with harsh cough. So what is the diagnosis?
Yes.
Croup. What is the causative organism?
Influenza, correct.
So I think all agree about that.
Yes.
Okay. So be familiar with the management. It's a common question in the exam. So if the patient has mild symptoms, what is the management?
Oral dexa.
Oral dexa. Okay. If the patient has severe symptoms,
Nebulize
adrenaline.
Intervention for
nebulized adrenaline. Okay. If the patient has mild symptoms, given dexa, after that deteriorated, what is the next action?
Then the
Nebulized adrenaline.
Nebulized adrenaline. The patient you give mild and you give him oral dexa and he vomited. What is the next action?
Repeat the dose.
Repeat the dose.
Excellent, guys. Repeat the dose, or you will give nebulized
Budesonide.
You will.
The patient is vomiting. Don't give him repeat the dose. The patient is vomiting.
Nebulized adrenaline.
Nebulized budesonide. Nebulized
Yeah, yeah.
gluconide.
Yes.
Why I will not give nebulized adrenaline? Because it's a mild.
No need for
Yes.
adrenaline, yes.
Mild, yes, mild but vomiting. So no need for adrenaline here, right?
Yes.
Yes, these are the most common. And if the patient has indication for admission, what are the indication? Give me 2 indications.
One of them is not responding.
Okay.
Second one, the score more than
The temperature is more than 38 degrees Celsius.
Presenting late time.
Desaturation.
At rest.
Poor oral intake.
according to
What
the
is,
score.
what is the common indication for intubation?
Airwaves,
Hypoxia.
obstruction, hypoxia, SBA2.
GCS less than 8.
Yeah, GCS, yes.
Despite treatment, it's already also increased work of breathing.
Yes.
Okay. Thank you, guys. Thank you for cooperation, and I wish you get benefit. Inshallah, we can continue.
Thank you, Doctor. And you are a great.
Thank you so much, Dr.
Thank you,
Hani.
Dr. Hani.
Thank you, Dr.
Appreciate your effort. Thank you.
Thank you, Dr. Hani. Thank you very much. We are
Thank you
grateful.
very much, Hani.
Tomorrow time. Thank you, Dr. Hani.
Thank you, Dr. Hani.
So tomorrow we'll
Thank you,
finish
Dr.
all the
Hani. Thank you.
videos.
Thank you.
Thank you.
Thank you, Dr. Hani.
Thank you. Thank you for your efforts, Dr. Hani.
Thank you.
I will say it in Arabic. الله يجزاك عنا خير دكتور هاني.
جزاكم الله خير دكتور هاني. ربنا يجزاك خير.
جزاه الله خير إن شاء الله.
Inshallah, all will
Dr.
pass.
Hani?
Inshallah, all will pass. And also, yeah, inshallah, I will try to start early.
Yes, early.
To give you time to sleep. Okay.
Yes.
But again, please don't focus on the questions itself. Think about the relevant information.
Yes.
Yes, okay.
Okay.
شكرا دكتور
Thank you,
هاني.
Welcome,
Dr.
guys.
Hani.
Welcome.
شكرا.
Welcome.
جزاك الله خير.
مع السلامة.
مع السلامة.